Dr. Woodall to come to the dais. The committee will come to order. The Oversight Committee exists to secure two fundamental principles. First, Americans have a right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform Committee is to protect these rights. Our solemn responsibility is to hold government accountable to taxpayers, because taxpayers have a right to know what they get from their government. It's our job to work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people and bring genuine reform to the Federal bureaucracy. Today, as we view a continued rollout of the Affordable Care Act, we deal with the Administration's selling technique. The Administration sold the health law to the American people with a simple, clear promise. If you like your plan, you can keep your plan. If you like your doctor, you can keep your doctor. After millions of Americans received notices that their plans were being canceled, the President was forced to acknowledge just how misleading he had been. The President apologized for his the President apologized for people who were misled by his claim and found themselves in difficult circumstances. And the quote is, "I am sorry that they are finding themselves in this situation based on assurances they got from me." We've got to work hard to make sure that they know we hear them, and we are going to do everything we can to deal with folks who find themselves in tough positions as a consequence of this. End quote. Now there's mounting evidence that the President's second promise is also untrue. Americans cannot keep the plan they like, they cannot keep the doctor they like, and it's increasingly clear that more needs to be done to keep the President's assurance that we will do for folks everything we can. Americans deserve to hear the truth. The Administration has been stringing them along with promises that every day are being broken. Many of these promises were predictable. Many of these occurrences cannot be reversed. But to the extent that we can bring the American people the truth of what's happening and reverse, in any case we can, the lowering of access to care, we must do it. Initially, in Minnesota, for example, the Mayo Clinic was only going to be open to people virtually within walking distance. Now it is open, because of the backlash, to at least people in Minnesota. But as a Californian, the ability to get reimbursed if I'm the California Exchange for the Mayo Clinic does not exist. And this is true throughout the country. Just last month, thousands of doctors were terminated from Medicare Advantage plan networks, including in 2,250 in Connecticut alone. Thousands of seniors are facing the loss of physicians they relied and trust on. In Florida, there are areas of southwest Florida in which no oncologist exists for patients who currently have life-threatening cancer. Many Americans who are shopping for plans on the ObamaCare or Affordable Care exchanges have found that they offer extremely limited provider networks that exclude their preferred physicians, physicians who they have built relationships with. Many parents are finding out that their child's pediatrician is no longer covered by their insurance plan. We now know that exchange plans exclude our nation's best hospitals, hospitals like Seattle's Children and Sloan Kettering, MD, Anderson Cancer Center, and the like. Unfortunately, millions of Americans are likely to find out early next year that their new health insurance plan doesn't cover the doctors who they most value and trust. Such limited plans demand that we ask the question, what quality of care will Obamacare actually provide? The access shock has prompted many Americans to ask, didn't the President promise me that I could keep my doctor, period? On November 19th, the White House press secretary explained that the President meant by that you can keep your doctor was that if you want coverage from your doctor, you can look and see if they're on your plan if there's a plan in which your doctor participates. Clearly, in the case of Federal and State exchanges, it is unlikely that the best and perhaps most expensive physicians will ever be available. Just this past Sunday, a key architect of the law explained, if you like your doctor, you can pay more for that doctor. Before the Affordable Care Act was passed, you had that right, and you had the right to pick a plan that suited you and paid for that doctor. In essence, the public is now being told if you like your doctor, then you can try to find a plan that carries them, and then you can pay more for that plan. But you're already paying more for plans that include items you don't want, items you didn't need and likely will not need. This is so unacceptable to the American people that there is no question, both through public polls and, if you will, even my Democrats no longer touting the main benefit of the Affordable Care Act being the improvement of affordability of health care, there's no doubt at all that if you could pass this bill again, you couldn't pass it in this Congress. Even if you had not read it and you knew what was going to happen, you would not vote for it. When our government, including the Congress, passed this law, we have a solemn duty to honestly inform the American people of what is going to happen. In this case, clearly the American people were misled. This duty is no more solemn when it affects the Americans' relationship with their physicians. That is a sacred trust. It is the most important thing in a life or death situation to many Americans, and it is a trust that has been broken. Today we will hear testimony from experts at think tanks and institutions. They will be on our second panel. We have concluded that the first panel should include 3 doctors who have actual life experience practicing with patients and realizing what can or cannot be done, what should or should not be done, and direct experience of what is happening under the Affordable Care Act, not just to their practices, which are businesses, but to their patients, who are human beings in need of their care. Today, the testimony from these physicians will describe in the most candid and personal terms exactly how the Affordable Care Act, or Obamacare, has affected these patients in their practices. I'm sure these doctors will agree that there were problems in the health care system that needed to be reformed. The fact is, America had an imperfect system developed with a number of public and private forms of money, tremendous Federal taxes, insurance companies that were often difficult to work with, and the like. But a broken system that is repaired by crashing it in a wall is not, in fact, a fixed system. And with that, I would recognize the gentleman from Maryland for his opening statement.
Thank you very much, Mr. Chairman, and thank you for calling this hearing. This week I had the tremendous honor and privilege of traveling to South Africa as part of our nation's delegation to honor the life of the late President Nelson Mandela. It was an inspirational trip, a life-altering trip, because I had the opportunity to reflect on the amazing changes that one individual working with determination over a lifetime can bring to millions of others. There will always be forces aligned against progress, against equality, and against basic human dignity. But Nelson Mandela's life reminds us that our mission on earth is to transcend these destructive forces and always pursue the betterment of our fellow man. As I traveled back yesterday on the 20-hour flight home, I began thinking about today's hearing. And I was amazed again at the significance of what our nation accomplished with the Affordable Care Act. Before we passed this landmark law, millions of our own citizens could not obtain health insurance because they had pre-existing conditions. And we allowed insurance companies to discriminate against them. They charged exorbitant premiums that were prohibitively expensive. They attached riders that excluded care for these illnesses. And in many cases, they denied access to health insurance altogether. Think about this. Before we passed the Affordable Care Act, there were about 50 million people in the United States without health insurance. 50 million. That's almost exactly the population of the entire country of South Africa. Before the Affordable Care Act, we had an entire nation within a nation of people without coverage. No insurance for doctor's visits, cancer treatments, prescription drugs, or hospital care. That was a shameful and immoral legacy for a nation as prosperous as ours. 3 years ago, after decades of inaction, Congress and the President passed the Affordable Care Act. We finally banned insurance companies from discriminating against people with pre-existing conditions. We prohibited insurance companies from charging higher prices for women than for men. We eliminated junk plans that collected premiums but then did not pay hospital bills when the people got sick. The result today is that tens of millions of people now have something they did not have before we passed this law: the opportunity and the ability to afford and obtain quality health insurance that will safeguard their financial security and recognize their dignity as human beings. Congress understood when we passed the Affordable Care Act that these changes would tend to increase premiums for a subset of people who already had insurance under the old discriminatory rules. So we put in place several measures to lower prices and control costs, including subsidies to help people buy insurance, a requirement that insurance companies spend at least 80% of premiums on health care services or offer rebates to consumers, and reviews of proposals by insurance companies to raise their rates by more than 10% in a year. The good news is that the actual premium rates have now been submitted by insurance companies, and they have come in much lower than expected. In September, the Department of Health and Human Services issued a report explaining that actual premium rates now being offered under the Affordable Care Act are 16% lower than projected. Based on this actual premium data, the Center for American Progress issued a report in October showing that these lower premiums will save the federal government $190 billion over the next 10 years, meaning 700,000 additional people may be able to obtain coverage. More broadly, the Centers for Medicare and Medicaid Services issued a report finding that national health spending has slowed to only 3.9% in the last 3 years, which is the lowest rate since the government began keeping these statistics in 1960. I understand that we will consider 2 studies today that assert that premiums are increasing for the majority of people in the exchanges. Both reports have significant, very significant flaws. First, the Heritage Report completely disregards the subsidies provided by the Affordable Care Act, completely. As a result, it inaccurately inflates the actual cost of coverage for consumers across the country. Second, although the Manhattan Institute study is better because it includes subsidies, it still compares, and I quote, apples to avocados, end of quote, as one commenter explained. It compares 5 plans under the Affordable Care Act with the 5 cheapest plans offered before the law passed. The obvious problem is that the old cheap plans offered vastly inferior coverage. To me, the most significant problem with comparing premiums before and after the Affordable Care Act is that it disregards the 50 million people who could not get insurance. If someone could not afford a policy that covered a pre-existing condition, the price of that prohibitively expensive plan is not considered. Let me close by offering a final thought. One of the things that Nelson Mandela will always be remembered for is his push for reconciliation. I respect the viewpoints of my colleagues on this committee, as well as those of our witnesses, and I understand that the Affordable Care Act is not perfect. I have said that many times. In that spirit, I hope that we can work together in a bipartisan way to improve the Affordable Care Act, rather than continuing to fight over its very existence. One of the things that the late President Mandela said, and I've thought about this a lot because it is so true. He said, "It always seems impossible until it is done." It always seems impossible until it is done. We could no longer disregard the experiences of 50 million members of our population. We can no longer ignore the pain, the frustration, and the fundamental inequality of this nation within a nation. And with that, Mr. Chairman, I yield back.
I thank the gentleman. Members may have 7 days to submit opening statements and other extraneous material for the record. We now welcome our first panel of witnesses. Dr. Patricia McLaughlin, M.D., is a ophthalmologist in a private practice in New York City. Dr. Eric Novak, M.D., is an orthopedic surgeon with the Ortho Arizona practice in Phoenix, Arizona. And I would like to recognize the gentleman from Georgia, Mr. Woodall, to introduce his constituent, Dr. English.
Thank you, Mr. Chairman. I appreciate that courtesy. We do have the great pleasure of having Dr. Jeffrey English with us today. He has been a tremendous resource to the Georgia delegation, not just to me and Mr. Collins on the committee, but to the entire delegation. I want to tell you just a little bit about his background. He earned his Bachelor of Arts in Psychology at Boston College in 1991, and then graduated from Dartmouth Medical School in 1995. Served relatively close by here as Chief Resident in Neurology at the University of Maryland in 1999, and to the great pleasure of all Georgians, has chosen to call Norcross home, where he is now the Director of Clinical Research at the Multiple Sclerosis Center in Atlanta and President of the Georgia chapter of Docs for Patient Care. It is with great pleasure that I welcome you today, Dr. English, and thank you so much for what you do for us, not just on the committee, but for us back home. Thank you, Mr. Chairman.
Thank you. And pursuant to the committee rules, I would ask all 3 of our witnesses to rise to take the oath. And please raise your right hands. Do you solemnly swear or affirm the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Please be seated. Let the record reflect that all witnesses answered in the affirmative. Dr. English, do you have time in your practice to watch C-SPAN? Well, then, for all of you, I'll give you the brief. We'd ask that, well, first of all, with unanimous consent, all of your opening statements in their entirety be placed in the record. In addition, any pertinent or even extraneous material you'd like to submit now or for the next 7 days will be included in the record. That leaves you free to use the entire 5 minutes on the clocks in front of you to say anything you'd like to say, but I'd ask that as that runs down, you try to wrap up. Dr. English.
Mr. Chairman and members of the committee, I want to thank you for inviting me to talk about how the Affordable Care Act is going to affect my patients. Practicing physicians who see real patients like myself, members on the panel, and the group at Docs for Patient Care, who have read the law and understand the law, have already predicted some of these outcomes that you mentioned earlier. None of what you're seeing and are about to see is unforeseen. The Affordable Care Act's problem is not a computer site. It would be common sense to me that a program that's designed in Washington, D.C. by people who don't take care of patients, that's supposed to affect people from Maine to Oregon, and it's sort of a top-down fashion with patients being so variable, is going to have a lot of unintended consequences, as you mentioned before. Unfortunately, those unintended consequences are the patients that we're going to talk about, and they're also your constituents and our fellow Americans. I'm a private practice doctor, but half of what I do is in a salaried position at the MS Center of Atlanta, which is a nonprofit for the treatment of patients with MS. What I'm going to talk about is not isolated to MS, certainly. MS is a disease of the brain and spinal cord, and it can be very disabling. Affects about 500,000 Americans. Most of the patients are female, and it affects them at a young age, 20s and 40s. In 1990s, we had no medications, and now we have 10. They're highly variable. Patients' response is highly variable, and they can have life-threatening side effects. So the MS patients require twice the number of staff and twice the amount of time to take care of. So these people can present as, young teachers, working mothers who all of a sudden can't walk, typical presentation. MS doctors must be able to identify risk factors and start and move very quickly to therapy. It takes a lot of experience to know how to do that, which is why we have about 5,000 patients. They come from 28 states and 118 of our 159 counties in Georgia, and they look at us as their primary care providers because they see us so often. We're now set up with the health care plan where we're looking at things like metrics that different physicians will be weighed against, and I think and my colleagues will probably touch on this too. The metrics, again, are set up by people, mostly in Washington, D.C., who don't take care of patients. If you comply with these metrics, there are bonuses. If you don't, there are penalties. And Section 302 to 3007 of the health care law actually states some of those penalties include removing physicians from government-approved insurance. So I want to give you a couple of stories, and hopefully I can finish in the 5 minutes. Number one was a report by CMS, or Centers of Medicare and Medicaid Services, February of 2012, and it said that I was an overutilizer of MRIs compared to my peers. MRIs are what we use to look at brain injury. They're routine protocol for MS. Not to do so can lead to disability, so we obviously don't want to not do the MRIs. So I called CMS and I said, first of all, who are my peers? Are they other MS doctors? They said no at all. My other peers also included orthopedic surgeons. And I also said, are you aware that I'm an MS doctor and that these are routine protocol? And I got no's to that as well. They did tell me on the report, though, that this information would be on the Medicare website in the future, and people would look and they would see that I'm that I did not meet their standards. Again, that will be on their website. I heard earlier in the opening testimonies about United Healthcare. Many of you have read United Healthcare have dropped quite a few providers. And according to the Wall Street Journal article, it mentions that this was in part due to managing its network using Medicare's new 5-star rating system that ties bonus payments that meet in certain measures on cost and quality. Well, you're looking at now a downgraded physician. I'm not off United Healthcare, but I'm downgraded because of again, in compared to my peers, which are fellow neurologists, general neurologists. They looked at cost and quality, and I want you to know that my quality was literally off the chart. There was a bell-shaped curve. We were over here thanks to my wonderful staff. However, because of cost, I was also too high, so that was what downgraded me. And the two areas of cost were, guess what, MRI, which we talked about, and the other was drug costs. The MS drugs are expensive, and I have absolutely no control over that. And again, my peers are neurologists who send me their most complicated patients that require these therapies. So I actually reached out to CMS a few years ago with a question, and I want to ask United Healthcare, but besides a December 2nd deadline to appeal, after 3 weeks of calling, we still now, 4 weeks out, have not gotten through to United Healthcare to appeal after the deadline. So what I want to know as a provider, am I supposed to not take care of MS patients? Or do I just take care of them, but I don't do what's required and limit my MRIs and my medications in order to meet metrics? And I think, again, this is just an example. I think physicians will be stuck with the way the law is written now, that we will be penalized for taking care of these more complicated patients. I will close by saying that I've submitted testimony on the state exchanges. They are going to have as equal a difficult time as far as access to medications and to providers who know how to care for certain types of patients like I do myself. And with that, I'll close. And again, I thank you for this opportunity.
Thank you, Dr. English. Dr. Laughlin.
Good morning, Mr. Chairman and members of the committee. I want to thank you for the invitation to be here, and I welcome that opportunity. I have submitted a testimony, which I hope you will all take the time to read. It is packed with details about the nuances of how these plans were designed in architecture with perhaps improper thoughts of the privates in the battlefield, and that being the patient and the doctor. You are all generals, and we respect the hard work that you have done to get this law passed. And as Mr. Cummings said, even in my own family, I can personally attest the fear that came when my father passed away, and my mother, at the age of 61, with a terrible medical history, lost her insurance because it was company-based with my father's company. And for 4 years, she was essentially uninsured. So I have walked that road, and I understand where you're coming from and the President in wanting to do something for the citizens of this nation who had such fears as well. However, in taking care of that, unintentionally, there were horrific events that are only starting to come to light, which is the part that concerns me so much. In my state society in ophthalmology, I serve as the third-party liaison, and I look at all things that insurances do as a patterned behavior, and I report on them, and then we take appropriate action as necessary, and most times, with good negotiations, we can sometimes make great strides. So I am an optimist at heart, and I believe that everything can be fixed. My former training in college and my graduate work was an aerospace engineer, and I had hoped to become an astronaut, but because of my mother's health, my life took a vast change. And I must tell you, as a little divergent comment, the pay-for-performance structure that we have now in Medicare for bonus pay, to most physician colleagues, I think we can honestly say should be scrapped. We are trained to give our best to our patients. We are paid, supposedly, to give our best to patients. We shouldn't be doing metrics that have no bearing on the field that we do. In my field of ophthalmology, some of the pay-for-performance measures could include something as ridiculous as doing a body mass index. What does that have to do with the health of the eye or what the eye says about other conditions in the body? Nothing. So you're spending Medicare money for ridiculous measures, taking our time in clinical practice to document this for someone who is a statistician who wants to run numbers. This is not what the doctor-patient relationship is about. And that is the only thing that this is about. My comments have no bearing on politics or what brought us to this point. We are now at T-minus 20 days and counting. The doctors and the patients are going to be having extreme difficulties in accessing care. And yes, Mr. Cummings, I agree with you. It's nice to carry a plastic insurance card to say you're insured. It's quite another thing to access the care. Whoever allowed the insurance companies to devise the current plans and how they're structured on the Affordable Care Act, and I might say affecting small businesses as well, outside or off the Affordable Care Act, leaves a lot to be desired. And I'm glad that I was put in the middle of this, because for everything bad, something good comes of it, and that is why I'm here today. As a small business, I insured my family and my 2 employees, and I had wonderful insurance. I was pleased with it. It was a small business plan. And I might tell you a little fact now that you will find surprising. In 2008, just as you said, those premiums raised ridiculous amounts every year. One year, it was 26% for this great insurance plan. I was in sticker shock. It got to the point in $2008 that each individual in my small business plan to have a fully comprehensive plan would have cost $859. These are $2008 dollars. I did the math and I said, I can't possibly afford this. So I contacted my insurance broker. I said, what are my options? And he mentioned the consumer-driven health plans. Not very familiar with it, a little bit leery about a new concept, I explored it. It took me 2 years to sign on, however. What that did in those $2,008, without the Affordable Care Act legislation, the insurance company took my premium of $859 and dropped it down to $300 for the same plan. So why? It did that because we had to assume a $2,000 first pay deductible expense. That's where the risk got put. The insurance company lowered the premium by increasing the deductible. We didn't have a deductible before for in-network coverage. We had a very modest deductible of $500 to go out of network. And I was blessed, yes, with an out-of-network plan. I continued this plan for all those years, and I was pleased. I was not pleased when I received a letter dated September 21st that my plan was going to be canceled, that it was not in compliance, it said, with the ACA. I'm no one to judge that. I have not read that 2,000-page document. I'm assuming the insurance company is telling me the truth. They said that that plan would be replaced by something comparable, and I trusted them for that. I've been with this company for years. I was a participating provider with them for years. Just like patients have trust in their doctors, patients have trust sometimes in their insurance company too, and I was one of them. The new plan rolled out. It took away my out-of-network benefits, which I might say I might be able to live with because under the high deductible plan, the in-network deductible was $2,000 for an individual, but the out-of-network was $3,500. I was less likely, I must say, even in my position, and certainly my staff, to go to an out-of-network physician because those first dollar amounts would be ours to bear. And being a responsible individual, you should take care of your bills. The new plan does not give out-of-network benefits, not just to me, but to all small businesses. The Affordable Care Act insurances do not allow for individuals out-of-network benefits. What I also noted with my new plan that was developed was a very crafted letter that implied that even though I was going to have an in-network plan, presumably of the same level as my current day plan, but only in network, it would now be called an EPO. The EPO plan was not going to have the same network of physicians that my current plan did. Both EPO and PPOs had the same network. The HMO physicians were a smaller, different network. So some doctors, by their contract, had the ability to be in one or the other network, but by some contracts, they had to be in all products. So what happened now was there was this term about I needed to be careful as the administrator, and I needed to inform my employees that they needed to check to be sure that all of their doctors that they currently saw in network. Now, mind you, the same insurance company makes this a bit difficult because you would assume if your doctor was in network before, why wouldn't your doctor be in network afterwards? But that was where the catch was. The new network was given a fancy name. It was called Pathway, with variations. Pathway X Enhanced, or just simply Pathway. I didn't understand that. I'm a participating physician. I never heard Pathway before. I just knew that I took care of the EPO and PPO levels. I took care of the HMOs and the point of services, but I didn't understand Pathway. I went to their website, and I looked this up. And what I saw was that actually these pathways were very restricted. So we have now an inability to refer patients. As an ophthalmologist, I will need a neurologist. But if that neurologist is not in that network, how am I going to give the patient with optic neuritis and sudden loss of their sight the ability to see a fine physician that I have sitting on my right? We have to fix this, and we have to fix this now. We have no time to play with this. Patients' lives are at stake. Acute care situations need a specific doctor to refer the patient to. It is not enough to send them to an emergency room. And by the way, many hospitals are not in these networks either. I thank you so much for your time, and I hope I can count on you to fix this. Thank you, sirs.
Thank you, Dr. Novak.
Thank you, Mr. Chairman. Mr. Chairman, members of the committee, thank you for having me back again. When President Obama made the case in 2009 that the U.S. needed to lower costs and improve access to health care, I agreed with him. On June 23, 2009, I told the House Subcommittee on Health that, quote, "The system within which you are allowed to provide care is as important to the delivery as the people providing it. So if we are not willing to put the same level of attention to detail into designing the system, it is doomed to fail." During that same hearing, Congressman Dingell announced that he, quote, "would never presume to tell somebody how to take out an appendix or to replace a knee, but he does know a little bit about drafting law. He's been doing it for 50 years. Since then, the health care law has failed to deliver on nearly every promise, including if you like your doctor, you can keep her, and if you like your health care, you can keep it. The problems and failings certainly extend to Medicaid. In February 2013, the Obama administration made clear their position about access to care for Medicaid patients in a court filing in the Ninth Circuit. Quote, "There is no general mandate under Medicaid to reimburse providers for all or substantially all of their costs," unquote. As Children's Defense Fund President Marian Wright Edelman said at that same hearing in June 2009, talking about a child on Medicaid who died, quote, "His mother couldn't get the dentist to take him because of low Medicaid reimbursement rates," unquote. In addition, Obamacare architect Jonathan Gruber's research and Austin Frack's research suggest that between 50 to 80% of all new Medicaid enrollees will actually lose private insurance as it is crowded out by Medicaid. And in Arizona, according to a 2013 Milliman report, most hospitals receive 70% of Medicare rates for Medicaid, which is unsustainable. While some will benefit from the expansion, the losers will far outnumber the winners. To respond to Congressman Dingell, he may not be saying how the surgery gets done, but he is certainly impacting who will get it and when. But the access problems do not end with Medicaid. As I wrote in August 2010, the health care exchanges are really just a variation of Arizona's 100% Medicaid managed care system, which the last time it was expanded has actually cost over 4 times what was predicted by the supporters. The policies available through the exchanges, even with subsidies, are, for many, far more expensive than Democrats and the President promised. And many have higher deductibles, co-pays, and co-insurance, and very narrow provider networks. Ortho Arizona, the group of over 70 musculoskeletal providers I am in, does not have a single exchange contract by choice. One reason is the required 90-day grace period for policies. This means we can provide 2 months of care thinking the patient has coverage, and then we are on the hook for payment, and the insurers have no responsibility. And Ortho Arizona is not alone. At least one major Phoenix area hospital system does not yet have a single exchange contract, in large part because the rates being offered are at or near Medicaid rates. I recently spoke with a retired professor from an esteemed New York medical school. She feels Obamacare is morally right, but she notes that none of her personal doctors take Medicare, let alone Medicaid. Unwilling to make a moral stand and not go to those doctors, the professor is blaming the doctors and seeks to have government force them and hospitals accept whatever payment the government decides, even if they go out of business doing so. And I strongly suspect we'll be hearing some variation of this very soon from the administration. Those who do not wish to defend the failures of the law are quick to say, well, what is your solution? I know this hearing is not focused on alternatives, but I want to quickly mention 3 areas that should contribute to the many larger proposals that do exist. This year, Arizona passed a first-in-the-nation price transparency law, I would add with significant bipartisan support. The law extends already only in the nation state constitutional rights to spend your own resources for legal health care services, but it also ends direct pay price discrimination based upon insurance status. This law goes into effect on January 1st. Ortho Arizona, since its inception in 1994, has focused on quality, utilization, and cost. We have shown repeatedly with payers that local, same specialty physician accountability is a reproducible and effective way to lower health care costs while maintaining high-quality orthopedic care. Intelligent Insights, a software company with whom I work, is a company that provides a platform that takes automatically collected data and provides analytics on that data combined with other sources of information. getting better, more accurate, unbiased information in the hands of everyone from transporters in the hospital to doctors to healthcare system CEOs to you, the policymakers in the country, has never been more needed. Ultimately, we must move to policies that ensure patients and families maintain control of their health care decisions, and that includes access to quality physicians.
Thank you. I thank all three of you. I'll recognize myself for a first round of questions. Dr. English, you said very well in 5 minutes a position. I just want to make sure I ask a question that makes it clear to all of us. Under the Affordable Care Act, what was often called ration care is occurring simply because you're being told that if you take an expensive practice, you could be locked out. Well, a doctor who sends off, cast off the kinds of people you deal with. In other words, a doctor, a neurologist who says, look, anyone who gets MS, I'm going to dump them onto Dr. English because Dr. English costs more, and I'm going to keep my costs down by not having those patients. He or she wins, you lose under this rating system. Is that pretty much a wrap-up of what you're dealing with?
Correct. That's my interpretation of.
But you can fix that. You simply provide marginal care and do less MRIs and so on, and then you'll be okay. Is that right?
Or I stop working for the MS Center Atlanta and just do general neurology, correct?
So you cannot take these difficult patients, and the same with an oncologist, who says, well, look, I'm going to go into a practice where I only deal with people up until the time they have a serious cancer event, but after that I'm going to dump that person. So the really sick, under the current system, unless we change it, find themselves undesirable either to get full care, which costs more, or quite frankly, to get to the doctor at all. That's what you're dealing with unless we make these changes.
Yes.
Dr. Novak, transparency is a good thing. And certainly the person who walks in and writes a check or hands out cash for the service should not be disadvantaged. What happens, though, if, and I support that, I really, from my bottom of my heart, find it hard to believe that your cash customer pays more, as they do in almost every state and every hospital in America, and they don't even know they're paying more because there's no transparency. But what would happen to the hospital system if everybody walked in and paid the Medicaid reimbursement, if that's the lowest rate?
Mr. Chairman, in my conversations with a variety of hospital system C-suite folks over the last few months, for the most part, they feel that they need to be able to be profitable at Medicare rates, which, talking to, again, major hospital systems, meaning they need to actually cut their operating costs by 30%. So I can speak to Arizona, where the average hospital Medicaid reimbursement is 70% of Medicare. And so, for example, for a total knee replacement, the average commercial payment is $24,000. Medicare pays $14,000. Medicaid pays $8,000. So were that to be extended further, there is simply no way that basically any of the hospitals, certainly in the Phoenix area, and I'd guess a bulk of the ones around the country, would stay open. I would add, by the way, that that isn't that unique a statement, because if you look at the Medicare actuary report that came out, there is an expectation that up to 25% of the hospitals won't be able to survive this decade anyway.
So one of the things that we have to do is figure out how to stop cost shifting. In other words, anyone, including the Federal Government, mandating a rate less than what it takes for an entity to stay in business, unless we're willing to work with that entity to make sure they can, in fact, live with that rate.
That's correct. It's important to know on the issue of transparency, as a very brief aside, remember that over 100 million Americans get their insurance through a self-funded payer. And so in this same example of transparency, what we found out was that, again, in Arizona, using Hospital Association data, that the commercial payment was $24,000. In Arizona, if you pay cash for a total knee replacement, it was $19,000. So as one of the executives of a privately held large company in the state said to me, in exchange for doing everything right for our patients, our employees and their spouses, we're paying $5,000 extra, or 20% more for that knee replacement. So when we look at what the health care price transparency law has done in Arizona, is it effectively creates a mechanism where not only can we protect the uninsured, but ultimately we're going to protect the folks who are insured by hopefully lowering the difference between what they're going to pay.
One quick question, and I'm going to respect the 5-minute clock very exactly today. The fact is that you're all seeing something else, I believe, and I'd just like a yes or no if you've observed it. Federal reimbursement for a particular event at a clinic or a doctor's hospital is almost always less than in a hospital, right?
Correct.
So one of the interesting things is if a doctor's hospital is more efficient than a hospital, a doctor's office is more efficient than a hospital, we don't say, well, we're going to try and get people to the most efficient rate by paying a fair rate to the doctor. Instead, we simply pay less to the doctor, more to the hospital, and it's causing hospitals to buy up doctors' practices, which means we're paying more. Is that correct in all of your experience?
Yes.
Thank you. Gentleman from Maryland, Mr. Cummings.
Thank you very much for all of you, for your testimony, and I appreciate your passion for what you do. And I want you to be effective and efficient in what you do, and it's so important. And Dr. English, you talked about the work that you do with multiple sclerosis patients. I'm very familiar with that whole area. Johns Hopkins is smack dab in the middle of my district, and so we spend a lot of time dealing with that issue. You also discussed the cost associated with it as being about $50,000 per year. Is that right? And that's a hefty price tag. And Dr. English, MS, of course, is a terrible disease, and I sincerely appreciate the work that you do to treat those patients afflicted with it. And I know you have concerns about the Affordable Care Act, but I have serious concerns about what happens to the 20-year-old woman or the 40-year-old woman who is diagnosed with MS but does not have insurance. And so do you agree with the Affordable Care Act's prohibition on discriminating against people with pre-existing conditions? Do you agree with that? I can't hear you. I'm sorry.
Yes. No, again, as we opened up, everyone agrees, I think, with the majority of your opening statement about the need to fix the healthcare system and pre-existing conditions, so sure.
Yeah. Do you agree that if an uninsured person with MS were seeking healthcare coverage in the individual market prior to the ACA, that person would have been very unlikely to have gotten insurance? Would you agree?
No. In my experience, at least in my state, the majority of my patients had very good access to care. Those who were uninsured, there were methods of getting them care. Again, as Congressman Issa mentioned, I'm cheap. The cost of seeing me is cheap. The medications are expensive, and those are usually subsidized by other fashions.
So prior to the ACA, insurance companies were allowed to discriminate against patients with pre-existing conditions and exclude them from coverage, and that's a fact. But do you think that people with MS would have been able to get health insurance, or would it have been so cost prohibitive that they wouldn't have been able to afford it?
Well, again, I would agree with your original statement that we need to handle pre-existing conditions. What I'm seeing here is that patients are getting, again, as Dr. McLaughlin said, a card that gives them access to nothing.
Yeah.
So I want to solve the problem that you exactly stated. I'm on board with you 100%, especially since at the time it was University of Maryland that was the MS center.
Right.
Now Hopkins has taken over, you're right. But at University of Maryland, again, I was taught that.
That's what you graduated from, Maryland?
From Maryland.
Oh, wonderful.
Two children born in your district. My wife got an MBA at Loyola.
Oh, fantastic. I'm a Maryland graduate, too.
Good.
Go ahead.
So, yeah, we needed to solve that problem. I don't think this, in my opinion, my experience and what you've heard here, this didn't solve that problem. And we're going to see these unintended consequences in the very near future, and you're going to hear it from your constituents.
Thank you. Dr. McLaughlin, I just couldn't help but think about the things that you said about your mother not having insurance for a short period of time. A member of my immediate family had they found some precancerous cells with regard to the breast and could not get insurance, could not get it for 4 or 5 years. And this was a young woman, couldn't get it. And how do we, and as I listen to you, I can see that you all seem to understand the problem here. On the one hand, we want to make sure that treatment that is provided is the appropriate treatment, and it does not, because we hear all these complaints about, and I know you've heard them, doctors giving too many tests and all this kind of thing. And at the same time, we want to get the results so that people can stay well or get well if they're sick. And because if they have to keep coming back, it's only going to cost the system even more. So how do you, I mean, you said, the last thing you said, and it's going to be, is written in the DNA of every cell of my brain. You said, I want you to fix it. That's what you said, didn't you?
Yes, sir.
And I want to fix it. I mean, what suggestions do you have based upon the things that you talked about today that you would suggest to us about fixing it?
Well, I'm glad you asked. Thank you so much. You see, the real problem with this, too, besides these networks being set up that are so restrictive, I also got a letter dismissing me as a participating provider from the insurance that would cover patients on the ACA. No one here intended that to happen, I'm sure. But that is what's happening to us as physicians. Or we're being put on these panels without knowledge that we are because of contracts we signed 10 years ago that had all products clauses. And you might assume, as someone who owns a business, that if you were paid X number of dollars by the insurance company to be as a participating provider currently with them, wouldn't you be offered the same fee just simply because you were taking care of the new government law? Well, that's not the case. They're coming in with fees that are sometimes 50% of Medicare. And as businesses, we can't survive. So back to your question, the other problem here is these deductibles, sir. Yes, there's subsidy, but that's for people who qualify for it. And maybe this is not universal across the nation, but in a large city like New York City, a studio apartment is $2,000 a month. How is a person earning $50,000, which by most standards across this country is not a terribly small amount of money, but someone earning $50,000 in New York City, paying $2,000 rent for a hole in the wall, cannot afford a $3,000 deductible for a plan that is being advertised as affordable because they take the bronze plan. The bronze plan in New York State for something like Emblem has a 50% coinsurance after that patient reaches that $3,000 deductible. What we have found when we went back to that 2008 level is that just simply having these high deductible plans slowed down healthcare utilization because patients were afraid that they would have to pay that first deductible amount. Other patients just saw the physicians, went to the hospitals, and then are in collections. We can't have a whole nation of patients in collection. And we can't have a whole nation of physicians' offices and hospitals fighting the system to get paid. And this isn't fair to the patients. So when we talk or there's rumor about a single-payer system, I think, in my heart, the quickest answer to help us in the next 20 days is eliminate these networks. Let everybody who's signed up stay in those plans, and those insurance companies must be made also to be transparent about what they will pay, which, by the way, up until this point, they haven't. I have colleagues that have no idea that they're even on these panels, and they have no idea what they're going to be paid. So let the insurance companies, so not to hurt their business operations, because we all want them to stay in business too for the rest of us, let them pay that same dollar amount as the access reference point, and then allow a negotiated fee between the patient and any doctor they want for a value for that service. Who is hurt by that? You will then establish a competition between physicians to keep prices controlled, unless you want to have one of those often spoken about concierge practices that charge enrollment fees of $24,000 for a certain 1% of this nation. But everyone else will keep their prices in check with this negotiated amount. The doctors will be able to remain in private practice, keeping them out of the facilities that are going to cost everyone more money. And the patients will have the ability to see someone for a modest fee if that's available, or they can negotiate some other fee. That's the only fix right now. But get rid of, please, those networks and allow the doctors to stay in business at the same time.
Thank you, Mr. Chairman.
Thank you. I now ask unanimous consent that the article today in the Wall Street Journal, or actually yesterday in the Wall Street Journal, entitled Junking the Obamacare Stats, be placed in the record. Without objection, so ordered. I now recognize the gentleman from Florida, Mr. Micah.
Thank you, Mr. Chairman. Perfect lead in putting that into the record. The title of the hearing is Obamacare Impact on Premiums and Provider Networks. Let's first talk generally about the impact on premiums and the people who have been affected so far that we know about. So far, and the Chairman just put this in the Wall Street Journal, said yesterday that between 4 million and 5.5 million people have had their plans liquidated. Isn't it your observation that most of these people are now going to face a higher premium, Dr. English? And actually, the higher premium and lower deductibility. I mean, higher deductibility and higher premiums, both. Would that be your guesstimate?
Well, I think there's so much variability. I think, as we've talked about, we want people to have.
But these people who've had existing plans now have been notified that they're not getting them, and with the new mandates in that. For example, I've been forced onto Obamacare. My deductibles are doubled or triple, and my premiums are up. And I think that's what 4 to 5.5 million people have seen. What do you think, Doctor?
I mean, I would answer that I'm reading what you're reading. I just can't give you personal experience with my patients.
Okay.
Because so many of them don't know yet. They don't know what they're having.
Yeah, well, again, with more mandates, the premiums are more. So they've shafted as many as 5.5 million people in their premiums. Dr. Novak, any comment here?
No, clearly we're seeing that it is highly likely that the number of net losers are going to substantially outweigh the number of
and they've signed up a whopping 364,682.
And we don't know if those are, since the country's starting out with a $5.5 million negative number, so we don't know who those people are. Are the 300,000 people or so just the people who previously had insurance but lost it? So we don't know who those numbers are, let alone whether or not they paid for it.
Okay, let's jump to the impact, again, the title here, Impact on Provider Networks. Here's another article from the Wall Street Journal about what the Chairman talked about in his opening statement. In my state, which has many, many senior citizens residing in Southwest Florida, their primary oncologist provider was the Moffitt Hospital. That's been dropped. Thousands of seniors now do not have access to this critical care. Is that the kind of impact you're seeing? Again, this is on our seniors. This doesn't involve Obamacare coverage. This is an existing Medicare Advantage, of which 28%, I guess, of all the Medicare people are on. This is an indirect result of Obamacare and what's going on in the marketplace. Is that correct, Dr. English?
Yes, I think Congressman Issa mentioned, again, the drafter of the law who was on the talk shows talked about paying more to see doctors on those plans. The state exchanges are set up. There's different exchanges in the state, so you can't, your providers, if they're in a different area, you can't even move out of that exchange to see those people.
But what we're seeing is absolute turmoil in the marketplace, Dr. McLaughlin. Seniors now, and they're the most vulnerable in our society and probably need the most medical coverage. And instead of getting coverage, they're searching for a doctor to serve them, as doctors have been thrown out in the cold. Dr. McLaughlin?
Well, absolutely, sir. And I can tell you in New York State, and we're such a large state, and really the behavior of the insurance companies has been quite different upstate New York as opposed to downstate New York. In the downstate area, 2,100 physicians were dismissed from Oxford United managed Medicare.
So it's not just Florida. We're seeing it across the nation.
And there is a reason for that, and it is a link to the ACA, because the CMS budget to these managed care companies was decreased from 17% to, I believe the figure is about 8%, to manage the Medicare beneficiaries. Now, with all due respect to the business operations of an insurance company, when they have a cut like that in their payments from the government to manage these patients, as a business, they have to do something to cut their costs. Morally and ethically, none of us in here are happy with that, but I can understand where that came about.
Doctor, you had mentioned the panels that are being set up, and I hear from seniors these rumors that certain ages, certain types of care is going to be cut off. Do you envision that happening?
You know,
I heard rumors 73, you don't get cancer treatment, or there's a possibility of not getting transplants and things like that. What do you see in the
Gentleman's
future?
time has expired. The gentleman may answer, Doctor.
May I answer?
Of course.
Okay. You know, a lot of that could be hearsay at this point. I mean, we heard rumors about death panels and things like that. But, you know, clearly rationing care is something that has to be part of this to make it work. It is not the appropriate answer, however. So I'm not quite sure what the facts are about at what age some procedures will be limited, but I would not dare think that that may not come.
Thank you.
If I could ask unanimous consent just to follow up for 30 seconds on this, because when the word death penalty is used, Dr. Bustani and others who are serving in Congress have a real problem with it. Dr. McLaughlin, you do agree, I believe, all of you, that medically sensible decisions about whether to use extreme health care options or not, in other words, decisions that are not always to do the most expensive and thorough, do change with age, and that medical doctors need to make those decisions. So the term death panel hopefully does not mean that doctors don't make a decision, that extraordinary measures sometimes are not appropriate for the elderly. And I want to ask that because I think both Republicans and Democrats found that word to divide us rather than unite us on your making decisions about what's best. So just a yes or no if you can.
The simple answer is most of us who are physicians will have a talk with the family and advise them what we feel is medically appropriate at the time. And we'll do everything possible to sustain life where there is life and to allow the family to make a just decision. We hope most people will do advanced beneficiary notices so that the individual has that choice and takes that burden away from the family. And if there's anything we can do as a society, we should be pushing individuals to make that decision. Thank you.
I appreciate that. I didn't want that to divide this panel because I think we're united on the need to fix health care. The gentlelady from Illinois, Ms. Duckworth.
Thank you, Mr. Chairman. Thank you for that comment. As someone who was accused of being involved in death panels at the VA, where they certainly use outcomes-based analysis to deem what is appropriate for veterans, that is a very sensitive statement. So thank you very much for bringing that up, Mr. Chairman. Dr. English, I just wanted to follow up with you a little bit. You know, the goal of giving Americans access to affordable, quality, life-saving health care is critical. It's not only the moral thing to do to make sure that getting sick in America doesn't lead families to bankruptcies, but as far as I'm concerned, it's common sense for our country's economic competitiveness and our government's fiscal health. I personally think that the Affordable Care Act made big steps in that right direction, but as you've mentioned, there have been some real problems with it that need to be fixed. And you spoke a little bit about the issues with CMS, for example, and how they rated your use of MRIs and incorrectly compared your use to others. I myself, you know, understand how different types of therapies will differ and the associated diagnostic equipment that you need to do to treat that. Are you saying in your testimony that the CMS decisions on how you are evaluated with your use of this is specifically to the Affordable Care Act, or are you saying that this is just part of their trying to improve the Medicare-Medicaid system?
I believe that outcomes measures are a major part of the Affordable Care Act, and they're using models like that PCORI. Some of those things were predated with the stimulus package. Some of that started ahead of the Affordable Care Act, but that's a big push. And when we look at the Medicare cuts for the future, you know, how will we evaluate outcomes and physicians and bonuses versus penalties? That's part of the Affordable Care Act. So it's a combination.
Do you support outcomes-based decision-making in medicine in terms of aggregate treatment, outcomes of various treatments for your patients? This particular procedure works better than others. I know you come from a very cutting-edge institution that is, according to your webpage, very progressive and aggressive in treatment, which if I had MS, that's what I would want. But do you support looking at outcomes?
I do. I think when they come from as far away from where the actual patient care is occurring, the more mistakes are made. And I think the ACA really pushes this coming from D.C., which was the wrong way. I really wish specialty societies were encouraged to come up with metrics, given a few years to say what is appropriate care in MS, what is appropriate care in knee surgery, et cetera, and that would have been a better way, in my opinion.
So what I'm hearing is not so much that looking at outcomes is a bad thing, but that the way CMS is going about it, using accountants to look at it versus relying on the healthcare practitioners to be the ones to inform that process of developing what those guidelines are, so that if they're going to evaluate the outcomes, if they're going to use outcomes-based evaluation of physicians who deal with MS, they should probably have some MS physicians who would inform that process of developing those guidelines, so that your use of MRI would be perfectly in keeping with other physicians who treat MS in an institution like in your setting, right?
Yeah, I mean, as I stated, I think the Affordable Care Act, again, is going to have all of these unintended consequences because it's built from the top down, not from the ground up. And so whether you like the law or not, I want you to understand these things, these unintended consequences are going to happen, and they're not unforeseen.
Right. Well, I happen to agree with you that we need to fix those unintended consequences, and I would love to be able to continue to focus on that. I don't know that repealing the law or unfunding it or defunding it is the way to go, but I do agree with you that there are many problems that need to be fixed. But there are good things with it. I have a pre-existing condition. I would assume that someone with MS would be considered to have a pre-existing condition if they were to enter the marketplace to try to find their health insurance now. Have you had experience with MS patients reaching lifetime caps, from insurance companies for their treatment?
Well, first of all, I would say everybody in this room has a pre-existing condition. It's just some of us don't know it yet. So
Good point.
You need to have insurance that actually will follow you once that happens.
Yeah.
So if everybody owned their own insurance, then once they got sick, there's no such thing as pre-existing conditions. So in my practice, the answer is no. I have never, to date, 13 years in Atlanta at our center, not been able to get the care to my patients through one way or another. Even with gaps, there's been ways to do that.
Well, let me fix that. I'm talking about caps from insurance companies. I think your institution does a fantastic job of raising alternate funds as a charity to provide charity dollars in order to cover patients who've lost the coverage from their own insurance companies. That's very different. I'm glad that you can get the care to the patient, but the fact of the matter is you're using other techniques, and I would think it would be better if the patient had insurance that stayed with them and would cover so that they did not have to rely on charity. I'm out of time. Thank you.
I thank you all. We now go to the gentleman from Michigan for his questions.
Thank you, Mr. Chairman, and thanks to the panelists for being here. Thanks for the work you do as well. Dr. Novak, let me go back to some questioning beforehand. And specifically, what are your views on the Independent Payment Advisory Board, or IPAB?
Sure. Thank you for that question. Obviously, the IPAB, which is supposed to be in existence, but no one's been nominated yet, to my knowledge, they say that it's not going to be involved, and it doesn't have the power to determine what care can and cannot be given. But as I believe not only are the people on the panel with me saying, but I think in the comments of the members implies that what the IPAB can do is determine effectively how much you get paid for it. And if the payment for something drops to a point where you cannot stay in business or keep your doors open if you continue to provide it, less of it is going to be available. So I think it's a bit of semantics, and I think some of the words can cause division. But the ultimate reality and the ultimate goal of the Independent Payment Advisory Board, if Medicare expenditures go up faster than inflation or 1% above inflation, is to reduce those costs. And they are going to go where the money is. So they're going to go to the expensive patients with MS and say, we're going to just pay a lot less because we think that means that centers like Dr. English's will just not make services available, and that's how they're going to lower the cost.
So it takes away decisions from the patient and the health care provider?
Correct.
To a great degree?
Correct.
I would assume that that's, from what you say, is a negative to the health care system.
Well, I think that ultimately the question is that how do we get the best health care to the mom who brings in their child to me after they fall at the park?
The best health care, what we deserve.
And the ultimate answer is trying to get patients and families involved on multiple levels to help try to make the best decision for them. Because certainly in my world, taking care of a number of fractures and acute injuries, I don't have the luxury of long-standing experiences with patients and families. And so you need to be able to get data so that families can make the best decision.
Do you have any evidence, Doctor, that competition and choice is a better way to increase value and reduce cost than government bureaucracies and their expertise?
Sure. Obviously, you have examples in certain parts of medicine where that does exist. But I think even, we can look, for example, in California more recently with what WellPoint has done with reference pricing for joint replacements. And by changing the structure, they've lowered the cost of joint replacements by 20% in, I think, less than 2 years. So the idea of creating transparency and really providing people, giving the opportunity to create new creative ways where you bundle your services together, you can actually provide high-quality care at a lower cost that ultimately results in better patient satisfaction.
Okay. Thank you. Dr. English, just to make sure it's clear where you stand, will ObamaCare limit your patients' treatments?
Yes.
In your testimony, you mentioned 10 medications for MS patients. A Washington Post article from 2 days ago said one way insurance plans under ObamaCare are keeping costs low is by not covering widely used MS drugs and requiring doctors to prescribe drugs in a certain order, which would compel patients to take drugs more toxic to them potentially. Have you found that to be the case?
This is our major concern, because I can't impress upon you enough how variable patients are in the drugs that they need, and without the ability to move quickly to one and switch to another, if I can't do that anymore, that's what will get me out of medicine, not the reimbursement stuff.
What does that do to your patients?
It's my teacher who's paralyzed, who I know I could do something for, but I can't, and I have to watch her stay paralyzed. That's my concern.
And puts them at risk at the very least.
Correct.
To take drugs that don't impact them positively, let alone produce the change that's necessary.
Correct.
You stated ObamaCare punishes you because you care for the most vulnerable patients. How does it do that?
Well, let's look at that. I think Congressman Issa had mentioned too, or it might have been Congressman Cummings, about, if our center closed down and I was looking for a job at a hospital and 5,000 expensive patients were coming that was going to bankrupt my hospital, which ones do you think would sign up to take me on? I want to work, like University of Maryland, the trauma center. I learned there. That was incredible, taking care of the sickest of the sickest, but I love doing that. And I don't see how, under these payment models, that any hospital system is incentivized by taking care of the sickest patients. It will be disincentivized based on outcomes.
So what we're looking at is a two-tier. Those that can't afford it for specialized treatment, have the money to do that, and then all of the rest of us.
Correct.
I thank the gentleman. We now go to the gentlelady from New York, Ms. Maloney.
Thank you, Mr. Chairman and Ranking Member, for calling this hearing, and I thank all of the panelists for their testimony and participation, particularly Dr. McLaughlin, who is from the great state of New York, which I have the privilege of representing a portion of it. And I do believe that you've raised some important concerns, but I truly do believe that the Affordable Care Act really is important legislation, and it is by no means perfect, but it really addresses some of the massive deficiencies in our nation's healthcare systems, such as covering pre-existing conditions and providing coverage to over 30 million Americans that did not previously have coverage. And while I do want to get to your concerns and understand them in a deeper way, I would like to take a moment to highlight some of the successes of the marketplace in my home state of New York. Earlier this week, the New York State of Health reported that over 314,000 New Yorkers had completed their applications for insurance, and over 100,000 New Yorkers have enrolled for coverage starting on January 1st 2014. And I understand that 70,000 selected a private insurance plan, and one report stated that New York has the second highest raw enrollment numbers of any state. So there are some successes, but I do want to acknowledge that there's always room for improvement, and any massive new change in something as complicated as health care is going to have to face many improvements, and we need to be willing to work together on both sides of the aisle to correct deficiencies and challenges that we see during this implementation process. But Dr. McLaughlin, I'd like to understand the concerns that you raised today, and I want to make sure that I understand completely your situation. You stated that you received notice last month from an insurance company stating that you would not be extended participating status on the new insurance plans in the Pathway Network. Is that correct?
Yes, Councilwoman, that's correct.
Yeah. And what about other insurers? Did you get similar letters from other insurers?
Well, the way this works is the insurance companies can only approach those physicians that happen to be already networked with them, under contract to them. So, for instance, I am not in the emblem system, so they cannot approach me or do anything to me involuntarily. And that's important to understand.
But can you approach them, another insurance company? Would you be willing to participate in any plan on the exchange? Can you approach another plan?
I'm assuming that that door may be open. However, what is clearly evident by the plans that I am already under contract to, Blue Cross for the main one, they made a decision, for whatever reason, that they had enough participating physicians to form this pathway network, which I might add, by just looking at the ophthalmologists serving Manhattan in that list, came to less than 150 names, of which most of them were in solo practices with no affiliation to large group contracting forces. So these physicians happen to be under contract to that company for the lowest fee reimbursement for the same service that another physician who's part of a faculty practice or a large group practice would get. And as insane as that sounds for doing the same work, physicians are paid differently in the current system depending on how large a group you belong to and what negotiating power comes with those numbers.
Well, have you appealed the decision? I know that they are trying to save money, and in fact, the New York State testified or released a report saying that the people that had enrolled, 100,000, were seeing premium rates that are as much as 53% lower than the rates in effect in 2013 for comparable coverage. So that is great news for them, but they are looking for services that are more affordable. But you can appeal these decisions, as you know, and as you know, particularly in New York State, it's being run by the state, and state insurance is regulated by the state, and you can appeal to the New York State Insurance Commissioner, and I would be happy to work with you in setting up such meetings if you would be so interested. But have you appealed the decision?
There was not an opportunity mentioned in that letter for appeal. It was a unilateral decision. There was no notice in there that I even had a right to appeal. I must say also that I had an amended contract to my United Healthcare participating status, and that also said that because I was not in an Oxford Liberty current network, I would not be put onto the Affordable Care Act insurances. So that was an automatic opt-out, and if not an automatic opt-out, I wouldn't be in it. And for those doctors who were in the Oxford Liberty current plan, once they see their fee schedule, they could then opt out.
And you can also get a navigator to help you, or a broker to determine what plan would be best and to help you with your appeal. But I'd be delighted to help you with an appeal if you're so interested.
I thank the gentlelady. We now go to the gentleman from Oklahoma, the head of our Energy and Healthcare Subcommittee, Mr. Langford.
Thank you, Mr. Chairman. Thank you all for what you do and the way you're taking care of patients. You're going through a lot of paperwork and a lot of process right now. that I can imagine the incredible amount of frustration that every day you're getting a new regulation, a new rumor, a new something that's coming out at you while you're trying to just take care of people and patients, what you love to do. So I want you to know from us, we appreciate what you're doing and how you're trying to focus on taking care of people. The problems are very, very real. Y'all are experiencing on the ground. We hear about them in our offices all the time. The numbers are out for the first 2 months of enrollment in the Affordable Care Act in my state in Oklahoma. They're now up to just over 1,600 people have been able to sign up in my entire state. To give you a point of reference, 1,400 companies got a letter 2 months ago that their insurance was canceled because they were in a small business group just in Oklahoma City. So just in one town in my district, 1,400 companies received a letter all on the same day that they've all been canceled because their association is no longer legal and they're out looking. And now we've had 1,600 people total in the entire state have been able to sign up. One of those was a small car dealership in Oklahoma City with 14 employees. They now are having to select a different insurance policy, a different company, and as the owner of the car lot told me, we can either select a plan that's much more expensive than what we had last year, but keep our doctors, or pay the same as what we had last year, but we've all got to switch doctors. But we can't do both. We can't both keep our plan and keep our doctors, or keep the price and keep our doctors. We have to choose on it. And it's been a very difficult process for them as a small business, as it is facing a lot of small businesses across their area. And Dr. McLaughlin, you've mentioned that even with your own practice. That's become a big issue. It's one of those many things that's out there. So let me just ask a couple questions about process things. By one count, this law creates about 159 new boards or agencies. We asked the Congressional Research Service to try to determine how many boards or agencies are created by this. They said it's not knowable at this point exactly how many. Dr. English, you've mentioned multiple times the difficulty of decisions being made in Washington, D.C. and getting passed on to you. And I have direct family members that have MS. And I'm very familiar with the process and the drugs and what's going on. And so I'm trying to process through 159 different agencies that are all setting these different rules, and you get instructions about how to take care of your patients. What does that do for you day to day?
Well, let me give you an example. I have, for the first time in my career, had patients who were healthy, previously not walking, et cetera, on a medication, doing great, who are crying in my office. People are really afraid, as you're seeing as well. They don't know whether their medication is going to be covered. I'm filling out forms, patients who are stable on medications, but they're not on the list anymore of the restricted provider list.
So we're talking about people that are currently under medication, doing better, stabilized in the process, that instructions are coming down to them to say, we may have to switch the regimen for treatment to a different drug or a different treatment regimen when they're currently stabilized right now.
Correct.
Because that sounds like someone in Washington telling you how to take care of a patient that's doing well with their treatments and saying, we're going to experiment with a different way to do this with your patient.
And in the Georgia State Exchange, we have no idea what medications are going to be available to those patients. And then again, we're less than a month away from patients coming into my office on those insurance plans.
And the current system as it's been set up is there's a discouragement to take the more complicated patients. So the more complex the case is, the more that is discouraged financially and in every other way from the Federal Government and from the system. Is that correct?
The current system, the ACA, the current system before the
current system ACA that's coming at us.
There are, as we discussed in my testimony, there are many things that will be discouraging me to take care of the sickest patients, yes.
Dr. Novak, you mentioned before all the issues with Medicaid that are out there based on the reimbursement rates and the number of physicians that do that. Half of the people that have now signed up for insurance nationwide are not signing up for private insurance. They're in state Medicaid programs. While they have access to care on that, what are the issues that they're going to face in the days ahead?
Well, I think the first issue, again, I think the crowd-out issue is something we really can't discount. Jonathan Gruber, who was really the architect of ObamaCare, and he was really an architect of the Affordable Care Act, His own research that he did originally in the 90s and then repeated in 2007 showed half the people who ended up on the government program lost private care. Again, the more recent study from Austin Fract, I believe from one of the Boston area universities, showed that up to 80% of the people who will get access to health, who will end up on expanded Medicaid, will lose their private health insurance. When you look at the smaller networks, when you look at the lower payment rates that discourage people to accept it or create long waiting lists to get access to it, I think that, again, there will be a few winners, but ultimately the number of losers is going to be a lot greater. And we'll see in orthopedics in Arizona that access to certain kinds of durable medical equipment, access to getting physical therapy after an injury in terms of limits, access to certain medications, all of those are severely restricted under Medicaid relative to what was existing in the commercial market.
Right. There's a tremendous difference between the hope of what this would be and the reality of what it actually is on the ground. With that, I yield back.
I thank the gentleman. We now go to the gentleman from Pennsylvania, Mr. Cartwright.
Thank you, Mr. Chairman, and thank you for all the witnesses appearing today. I believe the Affordable Care Act is a landmark law. It's obviously by no means perfect. It needs a lot of work, but all of us need to roll up our sleeves and work together and make it better. I had planned to ask all of the witnesses questions about provider networks, including Dr. Fader, but unfortunately the majority didn't inform us. They decided to change the panel structure today. They didn't inform Dr. Fader either. Dr. Fader was here and ready to testify at 9:30, and I would say that the fact that she is here and waiting for the second panel while we're not including her now is disappointing. But Dr. McLaughlin, I was interested in your testimony and your comments, and I'd like to follow up on some of the things that Congresswoman Maloney covered with you. It's my understanding that, well, a large part of your testimony has surrounded the fact that you got dropped by Empire, Blue Cross, and Blue Shield, right?
As a participating provider in the new plans that they are developing for small businesses off the Affordable Care Act exchange, as well as those serving the ACA.
All right, and just to, not to put too fine a point on it, you're still waiting to hear about larger employers, whether you'll be included in that coverage.
No, I am completely in that.
You are in that?
For now, yes.
Okay. So we want to look into, why these things happen. You got less than a full explanation from Empire, Blue Cross, and Blue Shield. Am I correct in that?
Yes, and everyone who is on my associated hospital staff had the same letter. This is not an isolated letter. This is clear across the board.
Right. So if I'm not mistaken, you got the Empire, Blue Cross, Blue Shield letter on October 29th of this year. Am I correct in that?
Yes.
Okay, so I want to talk about what efforts you've made in the couple of months since then to go over what the situation is and see what light you can help us shed on the situation. So I think you said you saw about 150 names of ophthalmologists who are included in the system. Is that correct?
That's correct.
Did you make an effort to compare different sets of facts? For example, compare your own credentials with those of the other ophthalmologists who made the list. I assume you're board certified, for example.
It's not based on that. We're all equal. What the basis clearly is the original fee schedule of the networks that the doctors are in. And as I said, if you are a complete solo practitioner, not part of a large group who negotiates a fee schedule with the insurance companies, you get what is called the standard rack rate from the insurance company. And those preferentially are those doctors that are on this network. They are the lowest paid of the physicians, and that is clearly what the decision is.
I don't mean to belabor the point, but are you saying you haven't really engaged in a comparison of your own credentials with those of the other 150?
There's nothing to compare. This is across the board. Everyone who is at my hospital was not offered the status. We are all of equal rankings, do the same work, the same exams. That is not what this is about.
So you think it's more about pricing. It's about money.
It's clearly about money.
All right. So, well, let's take that then. Have you compared the pricing? Have you compared how much it costs people to get treated by you and the other people who got dropped versus the people who got accepted into the system?
Well, first of all, I would have no way to compare that. You know, there are quite a bit of regulations on us also as far as fee schedules. We have antitrust regulations, and we are not allowed to collectively negotiate. So in honesty, I would have no idea to know pure facts as to what someone is being paid compared to myself.
But obviously somebody engaged in that comparison. That's why some people made the list and some people didn't.
That's right. That's maybe for you to find out.
Thank you.
You're welcome.
But another thing you mentioned was this idea, and I'd heard it before, that if you want to protect yourself as a physician, you want to join groups. And the bigger the group you're in, the more protection you have as we enter the new age. You are a solo practitioner. Am I correct in that?
That's correct.
So intertwined with that thinking, you have the least protection of anybody entering the new age. And I want to ask you, hadn't you heard this? Hadn't you heard what I had heard, that you're going to protect yourself by joining medical groups?
The gentleman's time has expired. The doctor may answer.
Well, let me just share this with you. I had been for 8 years a full-time faculty member at a major hospital in New York and enjoyed my time there. But I also saw the benefit of being able to be a physician, to make choices for the patient care in a way that I see fit, in the best care that I see fit for the patient that works for me and my patients. I don't want to give up that freedom by joining a larger group that has a non-physician administrator telling me how fast I have to see a patient and what I can and cannot do for them. That is a choice that I have in this country, thank God, and I want to keep it for my patients' sake.
I thank you. We now go to somebody who knows about patients' care. First on the list, Dr. Gosar.
Thank you, Chairman. Dr. Novak, can you discuss for me the confusion your patients are feeling about Obamacare, your services, and then also touch a little bit about urban and rural? You know, we're from Arizona, so there's definitely a dichotomy going on here.
Sure. I think that if there's one term that, regardless of your political party preference, that describes whether it's providers or patients or administrators or staff, it's confusion, because no one really knows. And I have 100 patients a week coming through, the bulk of whom will actually ask that question because they know I'm involved in different policy issues. And my answer is, we just don't know. They don't know what plans are going to be available. They don't know what services are going to be available. They don't know what medications are going to be covered. They don't know which hospitals they're going to be allowed to go to. So the issue here is basically abject confusion. And no one knows what's going to happen January 1st. And to say that that was an unforced error because of political realities, the great tragedy are really the tens of millions of Americans and hardworking American families that have been suffering emotionally because of the uncertainty that the law has created, because of work that was not done, the lack of transparency, the unwillingness to release regulations. I have patients who work for insurance companies, and I was hearing from them throughout the summer that large portions, they didn't even know the requirements that they were going to be forced to put into the software that they had to write. We're hearing that they are being required to be responsible for the data on these servers, but they're not allowed to get access to the servers to be able to test the integrity of the data that they are being held responsible for. So at every single level, unfortunately, the claims that were made to pass the law are not the reality. And the losers, this is not about the three of us up here. It's not about the dentists. It is about the fact that we have, we do need to do something about pre-existing conditions. But that was a small part of the population. The same amount of people, basically, that folks have recently been saying that, oh, it's a small number, don't worry about them, that are getting their policies canceled. It was really only 10 to 15 million people that had these chronic conditions, and we could have addressed that. Instead, we've totally uprooted essentially everybody. And real quickly about the Medicare Advantage issue, there's nothing tangential to the changes in Medicare Advantage as it regards the Affordable Care Act. remember that the Affordable Care Act cuts between $130 and $150 billion out of Medicare Advantage this decade, and that's why you're seeing these cuts to Medicare Advantage networks.
So when you're talking about pre-existing conditions, I'm going to ask you and Dr. English, we just exchanged, as the ranking member talked about, a prejudice to pre-existing conditions. We just traded one prejudice for another. Would you agree with that?
Correct.
Dr. English, would you agree with that?
Correct. I think you haven't changed. Correct. You haven't, in my opinion, increased care. You shifted care, and that's quite obvious.
Well, and I want to get to that, and I really want to applaud you. You know, I have family members and dear friends that have MS, so thank you very, very much. But there's this prejudice now because we're talking about acute care versus chronic conditions, right, Dr. English?
Correct.
And so you're handicapped when we're talking about chronic care, are we not?
Correct.
And so we're asking you to decrease time, reduce reimbursement, reduce the possibility of drugs, reduce your opportunity to standardize or to individualize individual treatment modalities. But I got a question for you. Did you see any tort reform in this bill?
No, sir.
Hey, Dr. Novak, did you see tort reform in this bill?
No.
Dr. McLaughlin, how about you?
Absolutely no.
Have you ever heard of solving a problem without putting everything on the table? Dr. English?
Say that again, please.
Have you ever heard of solving a problem but not putting everything on the table?
No.
It's foreign to me.
And the law did actually approve the opportunity for some demonstration programs for medical liability reform. But in the law, the plain language of the law says you may not do any demonstration program that includes any limits on non-economic damages. So the constraints were fairly significant.
You know, Dr. McLaughlin, I want to go back to this. We're reducing time for physicians to see their patients. We're reducing the reimbursement rates. We're reducing the panels, all choreographing hurting the patient. Would you agree?
Absolutely.
And you made the comment that you want to practice medicine your way. You want to individualize that, take your time, how you see fit, individualize the treatments, right?
Yes, sir.
How do you feel most patients would like to, would they appreciate your thoughtfulness?
Absolutely, because over and over again, I will have patients returning to me, perhaps even out of network, as they go to some of these larger group practices where physician extenders are employed to process patients literally through a quicker assembly line so that that facility can reap more benefits cost-wise out of the poorer reimbursements, but they may actually only have 2 to 3 minutes of face-to-face physician time in that. And most people are often told to bring a companion with them because when you're the one that is seeking care, you're only observing half of the response from that physician, and you're losing the other half, which is why most of us actually face umpteen phone calls after the fact because there's something they forgot to ask or something they didn't understand. So you can only imagine how that problem is magnified with only 2 minutes of face-to-face time with the doctor. Patients are generally nervous under those conditions.
I thank the gentlelady. Dr. Novak, I just want to make sure the record's clear. When you were talking about what wasn't in the Act in tort reform, you were talking prohibition on MICRA, like they've had in California since the 70s, limitations on things over and above full compensation for actual loss. Is that correct?
Correct. It does. I think there is a little bit of money for demonstration projects in the States, but in the law it actually says those demonstration projects may not include any demonstrations that include any limits on non-economic damages.
Thank you. The gentleman from Nevada, Mr. Horsford.
Thank you, Mr. Chairman. The title of this hearing is ObamaCare's Impact on Premiums and Provider Networks, but the majority of the opening testimony has largely focused on inadequate reimbursement from Medicare and Medicaid rates, which private insurance companies use in large part to set their own rates. So weren't the issues related to reimbursement rates under Medicare and Medicaid issues for the provider community before Obamacare and the Affordable Care Act were even law? Yes or no?
There's no question, but I think, and I'll speak a little bit, is that if the title is about provider and provider networks, we need to look at, this is not about us, right? It's about how do we get the maximum number of people the best personalized health care we possibly can. And the practical reality is Our large group employs nearly 500 people.
With
We need to be able
with
to
all
do
due
that.
respect, my question was, are Medicare and Medicaid reimbursement issues that the provider community were dealing with prior to the Obamacare Affordable Care Act ever becoming law? Yes or no?
Yes.
For the rest of the panel?
Yes.
Yes.
And yes.
So isn't the real issue that you all as the provider community want this Congress to focus on, as many of the doctors in my district in Nevada have talked to me about, is the need to reform the reimbursement rates under Medicare, specifically the SGR? Isn't that the focus that would help to address a large part of this problem?
I'll speak for myself, and I would say, Congressman, I don't think so. This isn't about creating a new Washington system to how to figure out how to pay people to provide care. This is much more broadly about how do we establish policies to allow patients and families to remain in control of their health care and health care decisions. So
why did you guys
reforming
bring up the
SGR
reimbursement rates under Medicare and Medicaid as one of the reasons why there is this lack of adequacy of network providers within some of the plans?
I would say it is one of the reasons.
Okay.
So it makes
so
an
if
impact.
the Congress could help address the reimbursement rates and reform SGR, would that help or hurt the process?
I think it all depends upon how it's done. And again, I'd refer you back to the position of the Obama administration, who said in a court filing this year, saying that there is no general mandate under Medicaid to reimburse providers, including hospitals in that, for all or substantially all of their costs. So the position of the administration appears to be—
SGR is focused on the Medicare.
No, but I'm just saying that
It's not the same thing. You're giving me a reference that's not my question. My question is on the SGR, which is largely the basis for how reimbursement rates to doctors are established by the private insurance companies.
I think that things would be improved if there was not an annual uncertainty every year for us to say that on January 1st, 2014, we're getting a 25% cut. So we tell our patients that under those conditions, we cannot continue to see you, so we have to decide if we're going to be willing to see Medicare patients until Congress chooses to fix the problem every year.
So if the Congress worked to fix the problem with the lack of reimbursement to cover the cost to the providers providing care under Medicare and Medicaid, that would help, not hurt, correct?
I think it would, depending upon how it was done, it might help, but there's always the possibility that new policies could not be helpful.
Okay. Well, later today, we will be voting on a budget deal that includes a rule on the SGR extension for another 3 months. Not reforming it, not increasing the reimbursement rates like doctors in my state of Nevada want us to do because they're not covering their cost. It's just extending it for another 3 months. So I would just hope that at some point in the government reform part of this committee, we would work to bring forward those bills. I have signed letters with my colleagues on the other side in favor of these reforms. I'm prepared to work on legislation to bring these needed reforms forward. But instead, we're having, kind of these dog and pony kind of show hearings that don't get at any of the real reforms to make the law work better or to address other issues that are unrelated to the law. Medicare and Medicaid reimbursement issues for doctors were a problem before Obamacare, before the Affordable Care Act was put into place. And so to somehow suggest that it's because of the Obamacare that these issues are happening is to fail to recognize the history of the problems in the health care system to begin with.
Would the gentleman yield?
No, Mr. Chairman. I just want to conclude my time.
The gentleman's time has expired. We now recognize the gentleman from Tennessee, Dr.
Thank you,
Oversight.
Mr. Chairman. I'd be happy to yield a minute to you to finish your thought.
Thank you. I was only going to say that I wasn't here in 1997 when they scored a big savings based on a theoretical reduction in the cost of doing business. You weren't here. It is something that I agree with the gentleman. We need to realize that simply paying doctors less and then reneging on agreeing to pay them less when the real cost savings didn't occur because we never legislated or did anything to help drive down the cost of delivery is in fact a very good point. And I agree with the gentleman that that fundamental change, which was scored before you and I got here, is not about just paying doctors more, because we did say, well, we're going to find ways to be more efficient in what drives their cost up. So I look forward to working with the gentleman on that. It won't come to our committee, but I certainly be happy to work with the gentleman, try to drive down the cost of doctors delivering quality health care. And I thank the gentleman for yielding.
Certainly, and reclaiming my time. And I will also add that we just had a Doctors Caucus meeting this morning. As you know, there's markups pending in Ways and Means and Energy and Commerce dealing with an SGR replacement. There's going to be a 3-month patch, but we are working with the 15 members of our GOP Doctors Caucus as well as our dentists and our nurses, and we are going to try to find something that has a sensible approach to reimbursing physicians, unlike the SGR, which over the past 15 years has yielded nothing, I think, but a 1.9% increase. And I think most industries would have a hard time making that work with rising costs in other areas. I wanted to put up a video if we could.
We will keep this promise to the American people. If you like your doctor, you will be able to keep your doctor, period.
If you are looking for, if you want coverage from your doctor, a doctor that you've seen in the past and want that, you can look and see if there is a plan in which that doctor participates. And
have unlimited choice. It's a simple yes or no question. Did he say if you like your doctor, you can keep your doctor? Yes, but look, if you want to pay more for an insurance company that covers your doctor, you can do that.
Okay, I'm sure this is probably something most everyone in this room has seen or heard, and maybe everyone across America. And practicing primary care medicine for the 20 years before coming to Congress, I know that a lot of my patients who had insurance probably believed the President. If you had an insurance plan that you liked and you had a doctor you liked and you were given that clear assurance over and over again right up through 2012, right before the election, I'm sure a lot of your patients were secured that maybe this health care law wasn't going to impact them. Well, now they're finding out that that's simply not the case. So I would ask you, we can just go down the line, what are your patients finding and feeling when they all of a sudden realize they've been duped?
Well, again, there's fear because they've had an established relationship, and patients will follow their doctors. What's wrong about the last part of that video is, as I said, if you're in a different part of Georgia and your exchange does not have me, but then you go into that exchange 3 hours away, now your primary care doctors are 3 hours away too. So you can't just pay more to see us anymore. You're excluded if we're not on that list. And UnitedHealthcare's website says I'm non-preferred, so you can still see me, but you have to pay more, and because your doctor is being penalized because he takes care of sick people.
Right.
The patients are numb. I think that's about all I can say. Okay. And many of the patients who had a state-subsidized plan in New York called Healthy New York received letters that that plan would end and they would have to go into the New York marketplace. I actually approached many of those patients that were in my practice. They never bothered to open the mail. They didn't even know that their plan terminated. I was the one that informed them. So these patients are numb, they're upset, and as you know, as a primary care doctor, you don't work alone. You work with specialists. So what Rahm Emanuel had said, that you can pay more for a plan that has your doctor, well, it may have your doctor, one of them, but it may not have the 4 or 5 specialists that you see also. So there's a discontinuation of care no matter how you look at this.
And Dr. Novak, I'm going to finish because you bring up a great point. Supporters of the health care law claim that 30 million people will gain insurance. Can you explain the difference between having a health insurance card, particularly one for a government program, and having access to care? And I'll just preface that I came to Tennessee in '93, a year before TennCare was instituted, which was a model for what we're experiencing now, and it didn't work. So I think you know very well that somebody can come in with that card and they need maybe an orthopedic surgeon, and if you're in a rural area at all, they may have to go 100 miles or more to try to find that doctor. And and you might have to hire extra staff just to stay on the line at night after clinic hours trying to find a referral or someone that can accept it. What are your experiences with that? And do you think it's a good idea to reform health care based on the expansion of Medicaid?
I don't think the data suggests that that's a particularly good idea, and I think it's the unfortunate reality, and then to touch on what you said, I know Congressman Gosar the last time I was here made that point exactly in his opening remarks, that what we are seeing, unfortunately, is that a plan that was supposedly designed to help those with some of the who need the most, we're seeing in rural areas there are fewer and fewer doctors available, and we're seeing in inner cities the closure of clinics, the moving out of primary care doctors, the near complete absence of specialists in many cases. And so unfortunately, the groups that we really do want to do things to be able to help, unfortunately, the law, while well-intended, I just think we need to recognize is not doing what it said it needed to be done. So I would make, this is beyond tinkering to make it better. It needs essentially a complete revamping and address the real problems.
I thank the gentleman. We now go to the gentleman from Virginia, Mr. Connolly.
Thank you, Mr. Chairman, and thank you to our three panelists. One might be forgiven from looking at this panel and the theater of it. Frankly, if Democrats had had the chance to put together a panel of 3 doctors, I guess we could ask you to wear your white coat. And I guess we could find 3 doctors, I know we could, who would praise the plan. The idea, and this doesn't in any way disparage the value of your opinion or your experience, but the idea that your experience is to be generalized as universal is false. And it's a false premise, and it does a disservice, in my opinion, to this discussion. None of you are policy experts, and none of you universally speak for your profession. You were asked at one point by one of our colleagues about how difficult it is to sign up. Well, if we're going to go through anecdotal experience, I can tell you that I and my entire staff must go on the exchange on Obamacare. All of us signed up, met the deadline. I know there was an accident. If you're under a certain age in my staff, the average premium cut ranges from 30 to 70%. They're happy as clams. The deductibles are comparable or better. The copays are comparable or better. I can tell you in my district of small businesses who are crowing about the fact that when they went on the exchange, they had better choices than they have currently, and they're going to save. I talked to one the other day with 4 or 5 employees. He's going to save $6,000 to $7,000 a year. It isn't an honest intellectual pursuit to deliberately cherry pick facts and to deliberately put together a panel of critics of a piece of legislation that is admittedly complex. You were asked about tort reform. As if tort reform was dispositive on the cost of health care. It is not. It is a factor. But of course, what the questioner didn't say, as a prelude to his question, was, of course, on our side of the aisle, we decided a priori to oppose it no matter what was in it. We didn't give it a chance. And the fact that an entire party decided to take a powder on a major piece of legislation precisely meant tort reform wouldn't be at the table in a meaningful way, at least as determined by them. Of course not. We had a prominent Republican senator in the other body who said, if we defeat health care, this is before we even knew what was going to be in it, didn't matter, it will be Obama's Waterloo. That tells you everything you need to know. It wasn't about health care. It wasn't about the quality of health care. It wasn't about whether you are in a plan or you are properly reimbursed. It was about a political game to try to make him a one-term president, and it didn't work. I hope someday we have a substantive hearing where we actually, as Republicans and Democrats, try to find out what's working, what isn't, and make it better. That is the history of transformative legislation in this field. Unfortunately, it's not the history here. We've spent 46 votes in this Congress to simply repeal it, defund it, or gut it. Not based on substantive analysis, not based on experience, but based on a political predilection to oppose this bill and this president, even though there are elements in the bill that actually came from Republican think tanks, the individual mandate being one of them. Not a Democratic idea, a Republican idea. And so I'm glad you're here. Certainly have enjoyed listening to your testimony, but I have to put it in a different context. You will forgive me. And it's too bad that the panel couldn't have been more balanced, and it's too bad Dr. Fader is kept waiting when she was under the impression, as were we, that she could join this panel to provide a different perspective. I yield back.
I now ask unanimous consent that the gentleman from Virginia, Mr. Connolly's website, which I'll put up there, from 2010 be placed in the record, in which he says, for the past years, my constituents have told me we want health insurance reform, but only if it meets certain tests, Connolly said. Will it bring down premiums for families and small businesses? Will it reduce the deficit, and will it protect choice of plan and doctor? Without objection, so ordered. We now go to the gentleman from...
Could I inquire of the chairman?
Yes.
Is it going to be the practice of this chairman to start to actually individually put members' websites into the record? Because we'd be glad to return the favor on this side of the aisle.
I have no problem at all. I asked for it because it was germane to your anecdotal statement of objection to their anecdotal statements. So it just seemed appropriate, and good staffing, as you know, Jerry. Somebody looked and said, heck, Jerry used to be for what these people are testifying we're not getting. That's all.
I stand by the website. Those were the three criteria I used, and that's why I voted for the bill and continue to support it, Mr. Chairman. So happy to have it. Just wanted to make sure.
I thank the gentleman. No, we put it in because it was a historic piece, right. And candidly, the requested individual from your side of the aisle is on the next panel, along with all the other non-medical doctors, and that's the reason it was divided. Medical doctors who were giving their anecdotal examples of what they see as practitioners, current practitioners, and then the think tank crowd will be next. And hopefully you will not disparage the think tank crowd for not being doctors.
No, Mr. Chairman, absolutely not.
Thank you.
There was no disparagement of doctors. There was just
Mr. Cummings.
Just a cry of the heart that some Democratic doctors not be at the panel.
If you had suggested one, we might have had him. Mr. Cummings.
Just for a second, Mr. Chairman. I would hope, Mr. Chairman, that we would not be engaged in putting members' campaign website stuff up or whatever.
This is not a campaign. We would not.
Whatever.
No, we would not put a campaign website
what was
up.
That?
This is in fact an official. This is property of the House of Representatives.
I just want to make sure. I'm just so concerned that we stay focused on this and not be distracted by certain things. And I thought it was a website campaign. I think that's. And so, but thank you very much.
No, and I appreciate it. Yeah. But you know, the reason we chose this was that it was set on the floor of the House. It's on a government site, and it's pursuant to exactly why we chose this question, which is what is the impact to doctors? And you know, I know a couple weeks ago when we were looking at failures of the website, something that we all are working on reforms to fix, we had a discussion about what about the fundamentals of the health care. Mr. Cummings, I will say something to you here today. You and I do not control, we were not the committee of jurisdiction for the Affordable Care Act, but the exact problems that these doctors are talking about are what we have to take a leadership role in fixing. Mr. Horsford has left, but a lot of it began in the 90s when we thought we could simply pay less from the federal docket in Medicare and Medicaid reimbursement. These are problems that are longstanding. Yeah. The reason I'm having him here today is I agree with what you said to me in a sidebar, which is, when are we going to start fixing some of the individual parts of it? The Affordable Care Act is not going away in totality, but these doctors, and I take Dr. English particularly, are telling us about a chronic problem, which is our doctors being incentivized not to take the tough patients. Mm-hmm. And in some cases, and Mr. Cartwright alluded to this, in some cases it's our government reimbursement. In some cases it's how insurance companies are reacting. And I will pledge to you today, I will treat how the government acts and how insurance companies act the same in trying to get these doctors to be able to practice what they do. And we can have a discussion about how much reimbursement comes out of tax dollars, but hopefully today, both in the first and second panel, we're dealing with what's happening currently so that we can fashion some legislation that has to be bipartisan if we're going to fix it.
Well, thank you, Mr. Chairman. I just want to make sure we stay on track. I keep going back to what Dr. McLaughlin said. She said fix it, and it can be fixed. And by the way, Mr. Chairman, I appreciate what you said to Congressman Horsford, because he did raise some very legitimate concerns, and I think that we can work in a bipartisan way. We can help these doctors be effective and efficient in what they do and help the American society. So thank you very much.
Thank you. The gentleman from Georgia.
Thank you, Mr. Chairman. I thank you all for being here. My colleague from Virginia characterized you as Obamacare critics. I would not characterize you that way. I don't know how you would characterize yourself. I would characterize you each as patient advocates. And if that leads you to be critical of the Obamacare legislation, then fair enough. But to the gentleman's point, I thought he was exactly right. Find out what is working and what is not, and make it better. I wish that had been the counsel this Congress had applied before the passage of the President's health care bill, because each of you has made testimony about patients that you had, patients that were receiving care, patients that were getting the individual attention that they need, who will no longer because of this new legislation. Those folks weren't having problems. We created those problems. And you all are in the caretaking business much more than I am. But the stories that you tell that touch me the most are the tales of the problems that we create, the uncertainty that you mentioned, Mr. Novak, Dr. Novak. There's no way to take those fears away. Those fears are real for those families today. If 6 months from now those fears turn out to be unrealized, we still won't be able to take away the pain and frustration those families have experienced today. I tell everyone at town hall meetings that I thought the President identified exactly the right challenges, that health care costs were rising too fast, and that many Americans did not have reliable access to care. I thought he crafted exactly the wrong solution to do that. I think we can work together to solve those problems. The concern is that, certainly from your testimony and from the experience of my constituents, we've created a whole new batch of problems. I want to ask you, Dr. English, you know my good friend Todd Williamson in Gwinnett County, Dr. Todd Williamson. He's a neurologist as well. He told me the other day, he's just a little bit older than you are, that here we are, largest county in the southeastern United States, one of the fastest growing. He said he's been in practice for more than 20 years. He has not seen a new neurologist come into Gwinnett County. I tried to look at the ages of folks in your practice. Are you the youngest in your practice, or have you found some young neurologists coming in?
I'm not the youngest anymore.
I
wish I was.
Because that is one of those challenges. I look at the dollars that we've poured into the President's health care bill. Just today, the headlines, Chicago Tribune, only 7,000 Illinoisans enrolled in Obamacare plans in the first 2 months. Weekly Standard, HHS awards another $58 million to Obamacare navigators. The list goes on and on. Bergen County record in New Jersey. Many New Jerseyans stuck in healthcare limbo as December 23rd deadline nears. AP, 398 Alaskans pick marketplace plans despite untold millions spent there. Oregon signs up just 44 people for Obamacare despite spending $300 million. What would have happened if we'd spent those $300 million on community health centers? I happen to be a huge community health center advocate. I believe folks are entitled to a level of care, and I believe we can provide that. Interesting sliding scales, ability to pay. We already had such a mechanism in place. My colleague from Virginia called this a pony show. When the question came to you, Dr. English, does Obamacare limit your patients' treatments? And the answer came back yes. I don't know why that's not the end of the conversation. I don't know why there are not 435 members of Congress who say, you know what, we care about people, and we care about people having access to care, and we want to improve the access to care for folks who don't have it. But if you have access to care today, and we're doing things in this body that limit the medical professionals' ability to treat their patients, why can't we all decide that's wrong and that we should go back and take another crack at that? The Affordable Care Act is important legislation, I heard from one of my colleagues, because it deals with pre-existing conditions and access to care. I want to ask you, since you've been characterized as Obamacare critics, is there even one of you who does not believe that we should deal with pre-existing conditions and that we should improve access to care? I'll start with you, Dr. English.
Of course we have to do all those things.
Have to do those things. Have to do those things. Dr. McLaughlin?
Sir, physicians have always given charity care, love of their heart, to people who couldn't afford it. Always did.
Always did.
And always will continue to do so. But what this has created, sir, is a roadblock of unsurmountable proportions. The high deductibles that were imposed on these patients is nothing more than them not having insurance. Can we understand that?
Dr. Novak?
The gentleman may answer, of course, Doctor.
I agree with you.
Mr. Chairman, I know my time has expired, but we have found that collection of ideas on which we can agree, and I agree with my colleagues on the other side of the aisle. We should begin working towards those goals, and we should do that immediately. I yield back.
I thank the gentleman. We now go to the gentleman from Massachusetts for 5 minutes.
Well, thank you. Thank you for being here today. I wanted to ask, I think it was Dr. McLaughlin who made a comment that her patients' policies were, the insurance companies did not renew her patients' policies, and as a result that was an issue. I wanted to ask you whether or not, when you were having this discussion with your patients who had their policies not reissued by their insurance companies, whether or not you looked and saw if those old policies had, as part of their coverage, the following services and benefits: ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorder services, including behavioral health treatment, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventative and wellness services and chronic disease management, pediatric services, including oral and vision care. Did your patients in each case have all of those benefits and services?
Sir, I can only speak of my small business plan because I...
Well, let me ask you, you gave me information about your patients and what you thought was their situation, so I'm asking you, before you reach a conclusion or an opinion on that, did you look at their policies to see whether or not they actually covered all of those benefits and services?
The policies I referred to as Healthy New York were state-run, and yes, they had all those benefits.
All of those services were in those?
But the reason why the state canceled
I wanted to ask you, so you know, you're going to tell me now that that policy had each and every one of those services already in it?
Absolutely.
Okay. And did you look to see whether or not any of your patients that you're talking about had been advised by their insurance company that they could go to an exchange in New York and compare and contrast what they now were offered with whatever else might be on that exchange as an alternative?
They received notification of that, yes.
Okay. And do you know whether or not they had gone and checked that out?
I can't tell you what patients do.
And do you know whether or not your patients were eligible for a subsidy? If, in other words, if they were earning less than up over 400% of poverty?
Again, obviously as a physician, we don't know what a patient's earnings are, but I can tell you from the careers that I see.
Well, that wouldn't be fair because you don't know what they're. So did you check to ask them whether or not any of them qualified for a subsidy, and if so, how much?
Well, I can speak even of my own staff who were covered.
I just want to know about these patients that you were referring
Yes.
to. You weren't checking about your staff. You told us about patients.
Some checked.
Some and some.
And some had a subsidy, some did not.
Okay. And do you know which of them are which, how many of each, and whether or not it covered all or some of the what they thought was an increase in the policy?
The closer that an individual, these patients, get to the upper limit of what qualifies for that subsidy, they were told that they would only save about $5 a month on the premium. So a subsidy doesn't cover everything. It depends on how far away from the maximum that is covered.
That's the idea of a sliding scale and subsidy, right?
Correct.
Okay. Did you also talk with your patients about the medical loss ratio part of the Affordable Care Act? That part that says that insurance companies have to now use up to 80% of their premiums for actual health services as opposed to overhead and management, things of that nature?
With all due respect to the patient population, sir, they don't understand a medical loss ratio.
Okay, do you?
I do.
Okay, so you're aware that in 2012, consumers saved $3.4 billion through lowered premiums based on those new standards?
My plan did not have that. I got no refund.
Well, my question to you, though, was that if you are familiar with it, do you understand that in 2012, consumers saved $3.4 billion through lowered premiums based on those new medical loss ratio standards?
I understand that, yes.
And do you understand that, in addition, companies that did not meet those standards issued $500 million in rebates?
Yes, I do.
Okay. Do you know whether or not any of your patients were beneficiaries of those rebates?
Some of them were, yes.
Okay. And I just want to close out. I'm not going to use all of my time on this, but with respect to a comment that was made earlier from somebody on the panel here about the history of this bill, and this was not a committee of jurisdiction. I was on one of the committees of jurisdiction. My memory is that during the course of debate of this particular bill, tremendous effort was made to try and have it be a bipartisan measure. And we reached out and asked for participation of both sides of the aisle. One side decided not to participate. And incredibly, even when certain provisions that people thought were generally good, bills that were drawn by the Republicans in that part were asked to be introduced, the Republicans refused to introduce them, and even when some 12 to 15 of them were put in as amendments, those people who had drawn those original bills that were now the amendments voted against them. So I think it's some indication of the effort that's been made to try and have this be a joint effort of all across the aisle, of everybody working on this, shows from the earliest parts of this whole exercise or whatever, a concerted effort, I think, on one part just to not even be involved in it and not participate in trying to make it the best project it could possibly be. And I think that's part of what we're seeing a continuation of here.
Would the gentleman yield?
I'm afraid I'm out of time, according to your strict standards, Mr. Chairman.
Okay, the gentleman's time has expired. The gentlelady, Dr. McLaughlin, you were cut off several times. Was there anything, because of limited time, but is there anything that you did not get a chance to answer?
Mr. Chairman, is it your turn to question? Am I missing something here?
It is the requirement.
You just asked for me to yield to, and I had no time to yield, so now you're just
No,
time?
I'm not asking any questions. The prerogative of the chair under the rules is to make sure that there is a full and complete, clear answer, and to correct the record if necessary.
You know, that's not at all accurate.
I am not correcting the record. This is a long-standing practice under both Republicans and Democrats. The gentleman had limited time. The gentleman, in his limited time, cut you off several times. If the doctor had anything that she felt was germane, I have always allowed witnesses to continue answering even after time has expired. Was there anything, doctor, that you felt you needed to fully answer that was not time for?
The purpose of this committee is to talk about the limited networks and whether premiums were indeed lowered or not. Was it not?
That's correct.
And as I said to Mr. Cummings, we have 20 days to fix how we are going to provide care to patients with limited access, and there is no debating that. We talk about MS. I will talk about ophthalmology for a second.
And I apologize. I'd love you to do that. I just wanted to give you time on something that he had asked, which included subsidies. He cut you off during your statement on occupations of your patients and so on. Please, I'm only trying to make sure the record is full. If there's anything you wanted to say about your patients and so on, that was the line.
The cutoff for subsidy.
Mr. Chairman, I would ask that you put it, if it's an answer to my question.
The gentleman is
the reason that
not
the
in order.
witness was asked to move to another subject was she was not being responsive to my question. Now, if you want to ask a new question, go a different direction, get some time.
The gentleman is not in order, please.
Well, the other is the chair, and I think we've got an issue here as to whether. And now you're going to shut the microphone on.
Yeah.
You're just a model of leadership.
Thank you. Please limit yourself to anything that you felt was asked that you were unable to answer. I certainly want you to be germane. That's why I did ask you to stay to what the gentleman asked.
$45,000, I believe, is the income ceiling in New York to attain a subsidy. $45,000 in living in New York barely makes it. So most of the people who are going to be getting these insurance plans will not receive a subsidy. and they are going to have a difficult time paying these deductibles and paying their premiums. Thank you.
Thank you. Gentleman from Georgia, Mr. Collins.
Thank you, Mr. Chairman. Look, I just have a couple simple questions. I have a daughter who fits the special needs category. Dr. English, I appreciate you being here from our home state as well as the rest here. And I'm just going to ask some very broad sort of questions because, and give a relative personal experience note here. One, I've heard it said many times, and I think one of the things that is being said here is you fix, there's a lot of things out there to fix. Well, this is one of the fixable laws. This is just one that is broken and it was inherently flawed, and that's just a disagreement that both sides of the aisles are going to have, and we're going to deal with that. I don't believe it can, but there are things that can be done. We have to now deal with reality. Reality is that, as in the case of my daughter who has spina bifida, early in life, she had, before 6 years old, she had 30 major surgeries, 3 of which went 8 hours plus, ranging just a vast array of different things. Now she is fine. She's 21 years old, and she actually rules the house, and nothing else is said. But doctors in her life, especially early on, were very important, and they still are. And we're making the transition, as I had a chance this morning to speak with Dr. English about the transition from pediatric to adult, and that's hard for a father, so I'll just leave that at that. But she is a young woman. The problem I have here, and I want you to address, I'm going to stop here and just sort of open it up, and then if you don't have a lot to say, then fine, we'll be done and we'll move forward. But this plan, the plans are hurting the very ones I believe they were intended to help, and especially with the zones, and especially with the areas of access, and especially on borders, and especially those who need multi-directional or multi-physician care. Could you speak to that? Not the politics of this thing, but to speak to what happens to a father who has a daughter named Jordan who may not be at 21, they may be at 6, so they may be at 5, and they're trying to get everything they can so that their daughter or son can move within the limitations of what you're now seeing. Can you speak to that for just a minute? And Dr. English, if you start, and anybody else would like to pick up.
Yeah, I'll start. The problem is, as you said, this is the group of patients that we really need to provide for. The problem is, again, I know your area. You're about an hour from us without traffic, depending upon the time of day.
3.5, 4 hours with traffic.
But so that's not a far place to go for somebody like that to see a pediatric surgeon. Boston, you're from Massachusetts, going to Boston is not a big deal for anybody in Massachusetts. But if you're out of the exchange district, then you don't have access, and patients like your daughter will not have access. Not to mention, we mentioned the Mayo Clinics of the world and Walter Reed and all of those places where a subset of patients have to go. So my concern is that, again, you have that card, but because of where you live, that's even going to restrict your access to the provider that you need.
And just to talk on that, if you want to, that actually increases cost because you don't have the collaborative effort that you could do in, say, a clinic setting or something else at times. And I think maybe you've had the experience, Dr. McLaughlin.
You see, it is a team approach in many illnesses, and the whole team has to be with this because this was allowed to be created now as all in-network coverage. Besides the high deductibles, all in-network coverage. That's not saying you can't go to see a specialist like Dr. English, but you'd have to pay for it, and that won't go to satisfying your deductible or your out-of-pocket. So there are flaws in this, and I'm not against the Affordable Care Act, but there are flaws in this that are increasing the costs to the patients, the very patients that you wanted to help. And this needs to be fixed.
Dr. Novak.
And there will be some families who will see some improvement. But what we've changed with the law is really the set of who the winners and losers are. And again, certainly to date, and there has been, frankly, not a shred of any actual real-life evidence that the number of losers, that the number of winners are going to even come close to approaching the number of losers.
Right. And I think that's the concern that we're seeing in our office. That's the concern that is coming on, that it was just a natural outflow of this, and there's things that have to be addressed. Look, this is a passionate issue. It is and not just for the folks on Capitol Hill. And in fact, for the 535 of us on Capitol Hill, we're just reflections of really the people in our districts who are dealing with this every day. The hearing's titled "ObamaCare's Impact on Premiums and Provider Networks." Frankly, I appreciate the chairman bringing this and the ranking member being here and the differences on both sides, but I would have to just say that the ObamaCare's impact on premium provider networks is a generic term for Obamacare's impact on the lives of people and families. And until we disconnect, and if we ever disconnect our discussions of insurance and health care and all this from the very people who need it, then we've made a mistake. And that's why this hearing is important, because it actually is dealing with those who actually need the help and the doctors that they need for day-to-day living. I appreciate you being here, Mr. Chairman. I yield back.
I thank you, sir. We now go to the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. And, you know, I'm pleased to report that I just came from a markup in Ways and Means, where on a vote of 39-0, we voted to do a fix for 3 months of the SGR and kind of looking after the needs and concerns of doctors. I also want to take a moment to just associate myself with the comments of my friend from Georgia, Mr. Woodall, who just spoke glowingly about community health centers and the accessibility as well as impact that they've had. I happen to have worked for 2 of them in civilian life and also had the good fortune to be president of our National Trade Association at one time. And I certainly think that they are a tribute to what can happen in the development of ambulatory care. And so I just want to thank him for that comment. As we begin, I want to make sure that we don't lose sight of the fact that many of these policies that we've talked about did not include basic services such as hospital care and prescription drugs. They were what many people call junk policies that provided very bare-bones coverage that would have resulted in catastrophic medical debt if policyholders became seriously ill. Back in September, a young woman named Aquilin Laurie requested to testify at a hearing before this committee, and although she ultimately did not testify, Ranking Member Cummins read part of her statement into the record. Like millions of other Americans, Ms. Laurie had a pre-existing condition, a rare blood disorder. In 2005, she needed emergency gallbladder surgery and suffered complications due to her condition. Although she had insurance at the time, her insurance company dropped her, refunded her premiums, and left her with a $50,000 hospital bill. Although she spent years trying to appeal this decision, she was not successful. Eventually, the hospital she was treated at decided to forgive the bill. My question to each of you, all of you are in the business of providing health care. You clearly have all interacted with insurance companies and know about insurance. Was this type of policy rescission common prior to the enactment of the reforms in the Affordable Care Act, and what were your experiences in each of your practices? And we could begin with you, Dr. Novak.
Sure. In my 13 years of practice and then 5 years of training before that up in the Seattle area, I've not seen it, and I have taken well over 1,000 days of on-call at multiple hospitals and seen over 50,000 patients. And most states actually have laws already that pre-existed the ACA that prevented inappropriate rescissions. So that's a different issue that I think is being conflated sort of a little bit incorrectly. So laws against canceling people's policy because you get sick have been against the law in most states for a long time. That is a different problem than this idea of people's insurance not being renewed. So now the idea that people who have pre-existing conditions not being able to find affordable insurance, there is not likely a person in this room, there is not a person I've ever come across in my 25 years of taking care of patients that doesn't feel like we need to do something or make policy changes to address that. The conclusion, however, is that the policies that were put forth through the Affordable Care Act are actually making these problems worse and not better.
Dr. McLaughlin.
It was illegal to cancel a policy because of an increased utilization of it for a serious medical illness. This wholesale non-renewal of policies is shocking. It has been reported that the insurance companies felt that small businesses were a losing proposition to them economically, and this probably became a great opportunity to just rewrite those policies, which is why we are where we are today with so many small business policies being not renewed. Hospitals, again, have always taken care of acute care conditions when somebody is uninsured, but we have to fix the problem that we're facing with now. As much as it is laudable to see that people who have pre-existing conditions can have insurance. Thank you.
Dr. English.
Due to time, I don't really have much more to say than Dr. Novak. I mean, obviously, we agree that there are changes that needed to occur, and we're just pointing out that, unfortunately, this plan is having huge amounts of unintended consequences.
Mr. Chairman, with your indulgence, could I just simply ask the panel if they would agree that many of these policies were, in fact, junk policies that we've been talking about?
I don't think that there's any evidence to date that the 5.5 million people who've had their policies canceled. I haven't seen exact numbers at what percentage of those are, quote, junk policies. A lot of them were ones because they didn't actually contain some of the new mandates in the law.
No one in my practice had a junk policy.
I have nothing else to add.
Thank you.
I thank the gentleman from Illinois. I'd like to recognize the gentleman from Michigan, Mr. Bentivolio.
Thank you, Mr. Chairman. Mr. Chairman, we now know that you can't keep your insurance even if you liked it. You can't keep your doctor even if you've been seeing him for the last 30 or 40 years. You can't keep your hospital. Premiums are increasing, and we have higher deductibles. Obamacare rated $700 billion from Medicare, including $300 billion from Medicare Advantage alone, to pay for the ACA. 2,250 physicians were terminated from Medicare in Connecticut alone. Most of the orthopedic surgeons in Dayton, Ohio, dropped. In Florida, 250 physicians from one medical center dropped. In January, Mr. Chairman, I'm sure we'll discover thousands, if not tens of thousands of people, to their dismay, that they thought they signed up for the ACA, but because of a glitch in healthcare.gov, did not. Mr. Chairman, the website itself is in question. A website that asks the most personal, intimate questions does not have the proper security protocols to ensure the personal medical data of our citizens that are safe and secure. Obamacare created a panel of 15 unelected bureaucrats called the Independent Payment Advisory Board, who have the power to control the types of treatment seniors receive through Medicare. And according to Dr. Jason Feldman and Dr. David Gratzer, this unelected body will have the unprecedented ability to single-handedly change the allocation of healthcare resources should Medicare spending exceed medical inflation, which, for the record, it consistently does. Dr. Novak, what are your views on this IPAB, I believe it's called, the Independent Payment Advisory Board?
Sure. As I mentioned earlier, I just think it's a serious area of concern. I don't think that for those of us, and actually for most families, that creating another new layer of bureaucracy that are making determinations about accessibility is a step in the right direction. I would add that I think that there's actually fairly significant bipartisan opposition to the Independent Payment Advisory Board because of the way it's structured and how their decisions effectively have the ability to bypass Congress.
Do you have evidence that competition and choice is a better way to increase value and reduce costs than government bureaucracy and experts?
I think there's a fair amount of evidence that if we increase transparency, provide more information to patients, that a lot of patients will make better decisions. That's also true on the physician side, and a lot of those solutions are a lot simpler and cost a lot less than the $2.5 to $3 trillion we're spending on the Affordable Care Act over the next 10 years.
Thank you. And do you think that many people signing up for coverage don't know that their doctor or their children's doctor will still be in their network and they'll still be able to visit their doctor, family doctor?
I think the evidence of this panel is not only do the patients not know, but we don't know either.
Mr. Chairman, we are consistently unearthing the lies, half-truths, and distortions of this poorly conceived law. Dr. Novak, what do you anticipate will occur next year when people go to their doctor and find out they're no longer covered?
Well, Congressman, I think there's going to, again, it gets back to this uncertainty issue that already on the provider side, we spend enormous amounts of time, as was mentioned, an enormous number of phone calls trying to sort through some of these very complicated issues regarding health insurance. And by the way, this is not just for people in the private market. It's not just for people on Medicaid. It's equally true for people with Medicare and the 130,000 pages of regulations that go along with Medicare. This is only going to grow. And so, at least for our practice, since we have no idea what the exchange will bring, and this 90-day grace period issue is such an enormous issue for us that we don't feel that we can actually see patients under these exchange contracts that we were pushed into without choice until this body or other bodies actually figures out what the rules are going to be so we can continue to provide services and be able to pay our staff.
Thank you very much.
Did the gentleman yield?
Yes.
Dr. Novak, I just want to make it clear. Under this 90-day plan, if you have, let's say, a $2 million practice, including the pay you, pay all your people, and so on, you could end up with 90 days, 1/4 of that, $500,000 of patients that aren't covered and don't pay. That's the kind of exposure you could have, is paying all your people, paying out $500,000 and getting back none of it. That's the uncertainty that was in the law. Is that correct?
Right. I mean, the concern is almost all insurance, is my understanding. There's always a 30-day grace period, right? Because sometimes we forget to send a check-in, things happen. But under the law, the exchange plans have a 90-day grace period. For the first 30 days, the insurers are required to actually pay the bill. But when we go do an insurance authorization on day 31, it's going to look like the patient has insurance. But the insurance company is going to hold payment. And if that premium is not paid by day 90, the insurance company says, well, it's not our problem, go collect it from the patient. And generally speaking, in those settings, talking to hospital people as well, your collection rate is about 1 or 2 cents on the dollar for that money. Interestingly, we had a conversation with one of the newer insurers at exchange that's going to be on the exchange in Arizona, and we said we'd like some kind of protection against this exact problem. We didn't have an issue in terms of what the payment rate was going to be for services. We just said we need some kind of a protection. And they were unwilling to provide us that protection, and so we walked away from that contract.
I want to thank all our witnesses today. I certainly think that we closed on a good note. The fact that there's something that I think all people on this side of the dais can agree on is that we certainly need to make sure, just as if you were taking a Visa or MasterCard and you checked it, and it was good, your expectation is that when you let the gas or the other product leave your store, that it would be honored, and not that 60 or 90 days later you'd find out retroactively you weren't going to get paid. So as we look at the many problems that were presented here on this first panel, I think that's certainly a good example of one that we look forward to working together to try to fix, and fix quickly. Again, doctors, I thank you for you're remaining in this industry. Remaining in this industry, remaining in your practices, and offering us some ideas of where we need to keep from driving you and doctors like you out. And I recognize the gentleman from Maryland for closing.
Thank you very much, Mr. Chairman. I want to thank all of you, too, for what you do every day. You have very, very important jobs. You bring a quality of life to life, and in many instances, save lives, saving sight. It's so important. I want you to be paid. I want you to be paid for what you do. At the same time, I also want people to have an attitude of staying well. And if they get sick, knowing that that insurance card that they have means something. And I heard what you said, Dr. McLaughlin, about these the various situations with that you found yourself in with your mom. And so some kind of way we've got to balance all of this. And, you know, Congressman Tierney was so accurate. A lot of these things probably could have been resolved when the bill was being put together, but there was a lot of give and take, and a lot of things happened that I think we could have avoided a lot of what we have here now. There are problems, but you're right. We have got to fix this, and it's got to be a can-do attitude. And not one to just throw out our hands and says, you know, because you know what? The people who suffer are the very people that you try to help every day. And so I thank you for what you do. And I also thank you for bringing, all of you, for bringing the passion that you bring to your professions. We understand. You're just trying to help people, you know, to get them well and keep them well. And we really appreciate you. Thank you.
I thank you so much for this opportunity.
Thank you all. And again, you'll have 7 days if you want to put additional statements or other material in the record. And we'll now take a short recess for the second panel.